We're live.
Madam Chairman, you may begin. We're live.
Great, thank you. Welcome to all to the Health and Government Operations Committee. This is a virtual meeting, so I ask for your patience. I'm supposed to say if, but I'm going to say when we encounter any technological or streaming issues. Before we begin, I remind committee members that this briefing is being streamed on the Maryland General Assembly's YouTube channel. The committee members will be muted throughout this briefing. If you have a question after each presentation, type question in all capital letters into the chat box on the right side of your window. I'll call on delegates to ask questions. After I call your name, please wait a moment while Dylan unmutes your screen. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist. Also, please keep your questions short. Today, the Health and Government Operations Committee will receive updates regarding hospital systems in Maryland and hear from the Maryland Department of Health about the transition to Optum. During this meeting, we're joined by members of the House Appropriations, Health and Social Services Subcommittee. We do welcome them here today. Please keep in mind this briefing is scheduled to conclude by 4 p.m. Secretary Neal and members of your first panel, when you're prepared, please begin.
Good afternoon, Madam Chair and Chair Resnick and the rest of the members of the committees. Thank you for having the Maryland Department of Health and Optum Behavioral Health here today. You can go to the next slide. Our goal has been to ensure that the 200,000 Maryland Medicaid beneficiaries who receive behavioral health care are able to receive these needed services and to ensure access to a robust and quality public behavioral health provider network. Just to talk a moment about grants to fee-for-service transition. Over the last 10 years, through both this administration and the previous one, and through multiple General Assembly sessions, the Maryland Department of Health has been steadily directed to transition the state's public behavioral health financing system from a grant-based system where a provider is simply handed a lump sum of cash to a fee-for-service system where providers are paid for services directly provided to individual clients, just like any other visit to a healthcare provider like their doctor. 3 basic reasons. Fee-for-service ensures financial accountability. The federal and state taxpayer know exactly what they're getting and who is getting those services. Second reason is quality healthcare measure tracking through the individual outcomes. And the third is leveraging Medicaid to gain federal matching funds and expand the number of providers through any willing provider. We moved from Beacon to Optum. Our previous vendor was Beacon. They handled claims from providers, reviewed these claims, and then paid the claims. And Beacon Health Options contract ended at the end of 2019. We competitively bid for the next 5 years and received 2 bids, one from Beacon and one from Optum. Beacon's bid, which was $50 million high over the 5 years, offered us less than Optum, and we subsequently found out that they had some technical issues and poor documentation as well. The contract's parameters included parameters from recent Department of Legislative Services budget analysis, which identified areas where increased oversight and cost controls could be implemented. So that was part of our objective, to get these assets. Optum's bid was recommended, reviewed with unanimous approval by the Board of Public Works in July of 2019. In September, Optum and Beacon began a rocky transition. Seems like there's a lot of that's going around. Through the fall and the winter, that largely resulted in Optum having to reconstruct an insurance system from scratch. As a side note, they are still having to clean up Beacon's data from the end of last year. As a result, Optum had a less than successful launch in January 2020. That became apparent very quickly, and I directed Optum to begin estimated payments in January through the beginning of August based upon the provider's historical average payments in 2019. Maryland paid out slightly over $1 billion in 8 months to about 2,200 behavioral health providers. This had an unplanned benefit of providing a stable cash flow during most of the restrictive months of the spring COVID shutdown to providers. However, providers have been required to submit claims for actual services rendered during this period, and as we will discuss later, will result in a reconciliation and a return of up to $163 million to the state due to our overpayment. We hope to work with providers on reconciliation through the remainder of the fiscal year in order to provide budget certainty to the General Assembly for fiscal year 2022. Next slide. Actual payment, system reactivation, July 2020. Optum has worked diligently to bring their system online in July, and they have been actively processing provider claims ever since. Their system is not perfect, but there's been steady improvements since July as the technical teams listen and learn from providers. Since the end of the estimated payments in August, Optum's system has processed and paid out over $453 million in payments and a weekly average of $32 million, which is pretty much in line with historical trends. I also want to say that we have daily progress reports, daily, ever since when, Dennis? January. So just mark your calendar. We've met with them every day. What's next? We're going to provide some service improvements to the new claims processing system, which Chad Burkholder, the Chief Operating Officer of Optum, will describe after I'm through. We're going to have a more detailed walkthrough of the reconciliation process by Maryland Department of Health Chief Operating Officer Dennis Schrader, and then a discussion of our provider outreach efforts, which have been significant, by Dr. Elia Jones of our Behavioral Health Administration. So with that, I'd like to turn it over to Mr. Burkholder.
Thank you, Mr. Secretary. Madam Chair, Chair Resnick, thank you for your time. Thank you to the committee's time. I want to address 4 key elements in my opening remarks. Most importantly and primarily, I want to express that Optum is frustrated and frankly very disappointed with how this implementation has gone. This has not gone according to plan, as Secretary Neal identified. And it is not at all how we operate our business. It's not how we want our providers, our clients, our customers to experience us. We're very disappointed and frustrated with how things got off to the start. The launch was very, very complex. Secretary Neal already referenced some of that. But frankly, even acknowledging the complexity, the launch performance was unacceptable. And Optum has been and will continue to be committed to getting this right. Second, I want to emphasize that claims performance has improved exponentially since the relaunch in July and August. Our performance in the first half of the year, as has already been described, is not acceptable. But I am very pleased that we've seen significant improvements since the relaunch. And however, we recognize that urgent improvements are still needed and still underway. Second, I'll address authorization performance, and this is the methodology by which Maryland participants gain access to care. And this performance has largely been stable since July 1 and has supported appropriate access to care. However, there have been pockets where there have been slower response times, and I'll address a couple comments to that. And then finally, I'll acknowledge the service performance that has been experienced by providers and, frankly, participants has been below our standards. And we've taken urgent steps to address that performance, and I'll talk about those steps, and I'll also talk about the improvements that we've seen in the last 6 weeks. So if we go to actually you can stay on the slide that you're on, but as Secretary Neal already mentioned, we do believe one of the larger indicators of system performance is the fact that the $453 million has been paid, $32 million roughly per week, and we're actively monitoring that to make sure that we understand where additional challenges may be experienced and what needs to be addressed to continue to make sure that that amount matches not only historical, but also what is, appropriate based on what's been serviced. Now, if you could go to the next slide, please. The turnaround time has demonstrated strong month-over-month improvement. We did, as you can see, experience challenges at the beginning of the relaunch. This was related to some steps that we had taken to actually hold back on some claims that otherwise may have denied inappropriately, and we did not want that to happen. And so we worked actively to address system challenges and then release the claims more accurately. And now, while not reflected on this slide, our month-to-date in November performance, we're operating in the 95% range in terms of claims processed within 14 days. You can go ahead to the next slide, please. Claims denials have been especially frustrating, frankly, to providers and to us as well. There's been a mixture of drivers, and you see some of those on the screen right now. And these include systematic challenges, whether they be defects or configuration changes that were needed based on improved understanding of state requirements. But largely, denial rate has actually been driven by accurate application of state policy and provider submission challenges. And we're working very actively with providers to address that. The screen demonstrates a denial rate currently at 16%, but that's actually not accurate. We've recently been able to update our data, and month to date in November, the denial rate is currently operating at 14%. This has improved from around 21% in the 6 months leading up to relaunch, and the overall denial rate since relaunch has been around 15.2%. Denial rates under Beacon as a comparison point were at 13%. So we are slightly above, but we believe that through ongoing work as well as certainly enforcement of state policy, we actually could see a slight differentiation between the two performances, although our objective is to continue to bring it down as low as it can possibly go, while also enforcing state policy. Optum is directly engaged with nearly 300 providers who are experiencing excessive denial to help them better understand how their submission practices are influencing outcomes. And also, as Secretary Neal also demonstrated, in some of those discussions, we absolutely learn things where we are being educated on things that need to improve in the tool. So there's been mutual benefit to those discussions. If you could go to the next slide, please. From an authorization perspective, authorization volumes have been in alignment with historical volumes, and we're seeing consistent volumes relative to what Beacon experienced. And 97% of those authorizations are received directly through the electronic portal that the providers interact with. The remaining 3% are supported directly by Optum, either because there's a need for expanded clinical discussion or because a provider has experienced a challenge and they need our support to get the authorization loaded. But either way, we believe the 97% success rate demonstrates that things have greatly improved, especially considering the fact that early in the year, that percentage was down below 50%. Also, of those authorizations, about 97% of those are being processed within the required turnaround times. I would acknowledge that since relaunch, there were 5 specific days where we did not meet our turnaround time obligation. Those were driven by a variety of operational challenges. But what I can say is, especially over these past 6 weeks, we've sustained between 97 and 99% adjudication of authorizations in the turnaround time. Now, let me kind of close my comments also by addressing the customer service experience. We fully recognize that the service to providers has been absolutely unacceptable. To be frank and open and honest, Optum absolutely underestimated the complexity of the service model that was needed for providers in Maryland. And we leveraged an external vendor to support the customer service function. And I absolutely acknowledge that this was a mistake, and we've taken recent steps to correct that mistake. We recently have made the decision to end the relationship with our external vendor as it relates to service, and we're bringing all service functions inside Optum's Enterprise Service Center. This is going to drive more direct accountability within my team and also more direct control. The transition has already begun, but we expect it to be complete by the end of February, although you'll see significant movement of the volumes starting in December and January. We also realigned accountability for managing the service functions and specifically the vendor performance. And over the past 6 weeks, we've worked really aggressively with the vendor, and we've seen significant improvements. Their daily call volumes are now down 17%. In addition, 29% reduction in the volume of daily service escalations. And we've also seen a 94% reduction in the provider relations email inventory box. We think this is reflective of improved first contact resolution, more attentiveness to processes that needed to be improved, and certainly much more attentiveness to specific gaps that were being experienced tactically by both participants and providers. To summarize, I just want to reinforce that Optum is committed to getting this right. We recognize this has been very challenging. Frankly, it's been very challenging for our organization as well. And we want to get this right to serve the state of Maryland, their participants, their providers, and we also want to get it right because it's what we expect of ourselves and of our business. While we've seen exponential improvements, we understand that providers are still feeling a lot of pain of some very specific issues, and we're committed to addressing those. I'll now turn it over to Dennis Schrader, MDH Chief Operating Officer, and he'll spend some time discussing the assisted reconciliation process.
Thank you, Madam Chair and committee members. I just want to briefly touch on 2 points. If we go to the next slide. Secretary Neal has already mentioned that we've paid out about $1 billion in estimated payments, and about $163 million we believe will come back to the state through the reconciliation process. This is a requirement of the federal government in order to receive matching funds and our state program integrity requirements from our Inspector General and legislative auditors. Next slide, please. This next one is really critical. We have been listening carefully to the providers, and they have given us a lot of insight into what they think it's going to take to get reconciliation done. And in that light, we have decided to start a 6-month period starting December 1st through May, which we will work together collaboratively in this, what we're calling an assisted reconciliation process. In that period, we'll be able to focus on reconciling accounts receivable and understanding the issues that they're facing from both the open issues and defects. During this period, we are going to waive the necessary timelines of 90-day appeals for dates of service prior to August 3rd, and the 60-day reconsideration period for both those timelines will be waived during that period for 6 months, which should be hopefully very helpful to the providers and take pressure off of them during this period. We also will collaborate with the providers once we get through this process sometime in June of next year, and there will be no recoupment going on until we get through that process. We've already sent out an alert to all the providers announcing this assisted reconciliation. In addition to that, we have offered to have dedicated reconciliation managers who will work one-on-one with the providers, and so far about over 1,000 of the providers have responded and requesting to engage in that process, and so far there have been about 207 reconciliation meetings held with providers, and that will be a very intense process over the next 6 months. So as we go through this reconciliation process, our goal is to begin that period where we can understand their issues, and then by next year, in the month of June, collaborate with the providers to design the recoupment process. So I'll stop there and turn it over to my colleague, Dr. Elia Jones, Deputy Secretary of Behavioral Health Administration.
Good afternoon. Thank you for having us. So at the end of the day, we want to make sure that all Marylanders have access to receive the needed behavioral health services that they need, especially during these very troubling and difficult times for our nation and our state. We are actively monitoring constituent inquiries to ensure that those who are in need, either through the state's crisis hotline or through local crisis centers and healthcare providers, are able to access quality behavioral health services. At the same time, as was previously mentioned, there are lots of opportunities for engagement with the provider community, including numerous weekly provider forums to provide opportunities for providers to share their concerns, to brainstorm about solutions, and to share best practices with each other, with MDH staff, and with our Optum partners. Our provider outreach includes meetings hosted by Optum's Provider Relations, of which there have been 184, WebEx training sessions, of which there have been 47 instructor-led sessions that have been attended by over 2,600 provider staff, monthly provider council meetings, of which there have been 4, and weekly operations improvement committee meetings, of which there have been 14. We look forward to Optum's system improvements over the next several months and toward partnering with all of our stakeholders as we develop and implement much-needed service quality and system of care improvement measures. For more information, there are a couple of documents that are attached to our briefing materials, one entitled an Optum Fact Sheet, and our Joint Chairman's Report for more details. We're very happy to take any questions that you all might have.
Madam Chair, you're on mute. There you go.
Yeah, thank you. I just figured it out. Delegate Johnson.
Thank you, Madam Chair, and thank you, panel, for coming to us today and give us this information. Can you all hear me? Can you hear me? Am I unmuted?
You are unmuted.
Oh, thank you. I do have a question, and I think I have several mental health facilities in my district, and in speaking with these folks, I think we can all agree that it was a rather disastrous rollout, and I'm really glad that you're taking steps to correct a lot of these issues and to help these folks work through this, because it's kind of been dumped in their lap, especially the reconciliation part, because they had big concerns about that. Another question that I do have is, I'm hearing a lot that they're unable to look at mass quantities of claims to work out their organization's outstanding unpaid claims. In order to do that, they have to manually look up each individual claim in their system, because the system's capacity is no more than 500 claims at a time, which is not up to providers, as they have thousands to look up at any given time. Do you have plans to correct that? So moving forward, they can, they have the capability to look these claims up instead of having to look them up manually, each individual claim at a time.
Whoever is best equipped to answer
Whoever's
that
best
question.
suited. Thank you, Madam Chair. Whoever's best suited to answer that question. Yeah.
You're welcome.
Madam Chair, this is Chad Burkholder. I'd be glad to address your question, Delegate Johnson. So we are actively engaged in several activities to improve the provider's ability to more easily assess claims performance. One is we are evaluating and currently engaged in systematic changes that will make the search process and the review process easier in terms of utilizing the Encato tool to review status of claims. However, there are other tools that are also being introduced right now that are tend to be industry tools that some providers utilize, which allow them to look at larger blocks of claims all at one time. You'll hear, terminology such as a 999 transmission or a 277 transmission. These are tools that providers utilize in addition to the use of the Encato tool to look at large blocks. Those two devices I just mentioned are currently in testing. They are scheduled to be rolled out with the release that's coming this weekend, assuming that all testing continues to go well.
All right, thank you. And the help that you're going to give this 6 months with the reconciliation, because that's huge. One of the clients here in my district, they have over 100,000 claims just for the first 7 months. So right now, the way it stands, there's just no way they have set up to reconcile those. So I'm glad to hear you're going to give them some assistance. And is there any way you could give us some feedback towards the end of March on how that help, the assistance with the reconciliation is coming?
Yeah, let me take that one, Delegate. Absolutely, and along the lines of what you're saying, we've actually broken the reconciliation down into 2-month bites so that they're not having to do all of it at once. And so we'll do January and February, March and April of last year, and we will definitely be able to give you a lot of feedback by March, no question.
All right, thank you. Thank you, Madam Chair.
Okay, we will now turn to Delegate Kelly, and do be mindful that we are going to end at 4 o'clock, and I need you to keep your question as short as possible and less response to the answer to the question, preferably no response. Delegate Kelly.
Thank you, Madam Chairman. I will be cognizant of that. I have a very quick question. It's for the Secretary. I do want to thank Mr. Burkholder for acknowledging that the rollout did not go well, and I want to acknowledge my appreciation that the claims are being processed a little bit more quickly now, which is very important. But my question for the Secretary is, the contract with Optum allows us to levy $25,000 a day fines if their obligations aren't being fulfilled. And since we're spending so much time talking about the reconciliation and getting money back from these providers that are doing what I consider God's work, the most essential work at the most essential time right now, I'm wondering if we've also considered addressing some issues of penalties for Optum for not fulfilling their contract.
So, Delegate, this is Dennis Schrader. Let me take that. There are two parts to that. We have in the developmental budget, which is the first cost, we have $8.8 million, and we are holding back $4.4 million till we get to the end of this, and then we will determine how that's going to play out. Secondly, we have taken an approach with Optum because of some of the things that Mr. Burkholder mentioned, that unfortunately Beacon had, over 10 years, had little to no documentation of how this system worked. And maybe that's one of the benefits of adhering to competition, because we found out through that process that we were really in a bad place. And so that had been the case for well over a decade. And what we are doing now through this process is developing the documentation to support this system. That's just one example. So our approach has been to partner with Optum so that the state is getting the benefit of a working system, and then we'll deal with some of these other issues later, particularly the $8.8 million that I mentioned.
Thank you.
We're going to move to Delegate Henson.
Thank you, Chair Pendergast. Thank you, Chair Resnick and Secretary Neal. It's my understanding that this system operates for the payment of claims through Medicaid. So people who have private insurance, they're not experiencing these same set of challenges with getting their claims paid. And so I was wondering if that has resulted in providers no longer accepting patients that have Medicaid, or if we have seen any providers who have just opted to drop out of the system altogether and no longer move forward. Do we have any numbers on that?
Go ahead.
We don't have, I think that's a very good question. Thank you for that question. It is a concern that we are concerned about. We certainly have heard anecdotally people saying things like that. However, we don't have any data to substantiate that. The Behavioral Health Administration is about to do another survey of our providers around their financial challenges at this time, and one of the questions we're going to be asking is to try to determine if people are making different decisions with regards to taking or no longer taking Medicaid patients at this time. So we should have some data for you about that in about a month or so.
Delegate Young.
Thank you, Madam Chair. I'd like to address this question to the Department of Health. What process do you use to independently investigate the customer service record of a potential provider? And going forward, do you have some very specific recommendations as to how you can work in partnership with the General Assembly to ensure ongoing transparency and accountability?
Delegate, could we get a clarification? Because on one level, we're hearing, do we have oversight of the providers themselves and their Medicaid record, or are you talking about their quality record? Maybe if we get a little clarification, that'd be helpful.
Well, clarification, when initially using a process to select or investigate a provider, for example, checking with other entities that receive their services, conducting searches for customer service complaints, searching for relevant lawsuits.
I can take that question. Thank you very much, Delegate, for that clarification. The way Maryland's system works, we are one of the few states in the nation that has a fee-for-service. 30 of the 50 states use their MCOs to oversee behavioral health. So in effect, as you have noted, the state has the responsibility for the provider list. Now, since we have gone from grants to fee-for-service, we have gone to any willing provider. And one of the things that Dr. Jones and I have spoken about is we really want to get more focused on the quality that the providers are rendering to us, because we spend $1.4 billion a year on behavioral health services. And how do we begin to shape the vendor pool based on those kind of factors? That has not been done in the past. Unfortunately, we were on the way about a year ago to move in that direction. This year, we got this bump in the road, but next year we are going to start back down that road, because that's a very important point.
Can I just?
Yeah, Dr. Jones, go ahead.
And I'll just add that for all of our licensed providers, most of our provider types, we do have an auditing process. We do have a process where patients can render any complaints that they might have. There is a process for licensing where we are getting background information. However, it is largely, as Dennis said, an any willing provider model that does not involve the same level of credentialing that you might have for someone who's paneled with a private insurance company.
Thank you for your response.
Vice Chairman Penny Melnick.
Thank you, Madam Chair, and good afternoon. So I heard the Secretary Neal state that since January 1st, there has been training and meetings, but there was no test environment and no access to the system prior to January 1st. Can you tell us why that is? And also, what is the plan to address the loss damages created from the backup payment, staff turnover, liability issues, fees that people incurred, line of credit that they had to ask for? Are you planning on using some of that money that Mr. Schrader referenced to? Thank you, Madam Chair.
That was quite a laundry list, Madam Vice Chair. I think I'd have to take them one at a time, and if you want me to, I will write up a
Absolutely, if
response.
it's okay with Madam Chair, thank you. Yes, thank you.
Mr. Secretary, are you going to address them, or did you say you were going to address them in writing? I was a little unsure.
I'm sorry, I might not have made myself understood. I would take that list and respond individually to each one, because I didn't come prepared to that level of detail, frankly.
So you mean you're going to respond in the future, not at this time?
Yes.
Okay. We'll see that in writing by when?
Well, I'd like a written list because I don't think I caught it all. And once we get the list, we'll respond.
Madam Chair, may I try to make it a little clear?
Yes, and if there's something you'd like him to address now in particular, maybe you could clarify that as well.
Absolutely, thank you, Madam Chair. So why was there no test environment and no access to the system prior to January 1st? Can you reply to that, please?
Frankly, I don't know the answer to that question. Chad, is that true?
Mr. Secretary, I can assist with that topic. So first of all, I would acknowledge, Madam Vice Chair, that the testing environment was far too late up against the implementation date. I would absolutely acknowledge that. That was driven by, several things. There was, in fact, a testing environment before 1/1, but it occurred in the December timeframe, and that was much later than any of us would have wanted. That was driven by several key factors. One, we had an extraordinarily brief time period by which to launch the new program. The contracts were finalized in late August, September, and that really left us about 2 months. I think as was commented previously, the documentation that was available to support the implementation was very, very limited during the implementation. And unfortunately, we found ourselves having to develop the processes at the time of also establishing the tool in the system. That was not anticipated, and that absolutely created a delay. And so then we ended up doing a lot of testing, as you have implied, in the December and then in the January and February timeframe. We have had a really robust engagement with providers since that time, in which we've used certain providers over and over and over again to assist us with testing of new capability, testing of capability before a release is about to happen, as well as piloting new options. And we're very thankful to many providers who've been so dedicated to being a part of that process, and we'll continue that practice. What I would say as of today, Madam Vice Chair, is that we have a much improved process today. Our success rate of rollout is far improved compared to what it was in December and then January and February, and we hope that that'll sustain us. So I hope I've addressed your question. I certainly would acknowledge that the situation was far less than I would have expected, and I think many contributors, unfortunately, to what drove that.
Thank you. Mr. Secretary, the other one is very simple. What is the plan to address the lost damages created from lack of payment to these businesses? Because we're getting so many emails. People are struggling, plain and simple. I know that Secretary Schrader replied to Delegate Kelly regarding money being held. Is some of that money perhaps going to be used to assist these businesses that suffer as a result of lack of payment?
Thank you for that question. That is largely a legal matter, and I'm sure that we're going to look into that, but I'm not so sure that's something I should speculate in a public hearing.
Thank you, Madam Chair.
Thank you. We'll now move on to Delegate Bhandari.
Madam Chair, I don't have a question. My question was already answered. Thank you.
Okay, we'll move on to Delegate Rosenberg.
Thank you, Madam Chair. Mr. Secretary, is there a need for any recourse against Beacon for its performance? And if so, is that adequately handled by the contract or existing law? A legal question, but I pose.
Yeah, it is a legal question, Delegate Rosenberg, but we all felt at the health department that getting this system fixed was the first priority, and then we would count beans afterwards to see, as Deputy Secretary Schrader said, there's some money that's being withheld, and we've reserved all of our rights. But this was a very important transaction that the transition didn't go well, and I didn't think that beating the incoming vendor with a bunch of legal action was the fastest way to get this problem solved, and I think my judgment was correct.
Except my question, and I understand your answer, was about the outgoing vendor, about Beacon.
The same thing, but
okay.
we needed to get the baton passed. But believe me, I have some ideas there as well,
Which we will be apprised of, I'm sure. Thank you.
Thank you, sir.
Okay, Delegate Resnick.
Thank you, Madam Chair. Before I ask the Secretary a question, I want to provide the HGO Committee a little bit of context. I know that the Appropriations Subcommittee knows this, but back in February, we held the budget briefing for this particular part of the budget for the BHA portion of the budget. And all of these problems we were made aware of then. This was back mid-February, I believe. The concern over the advance payments, the lack of documentation from Beacon being transferred over to Optum, the non-testing of the systems, et cetera. So we were aware of this. It has now been 8 months, and as many of the members have pointed out, we have been hearing nonstop from providers that these issues continue. My concern, Mr. Secretary, and here's where my question is that if Optum was so woefully unprepared to meet the challenges of this system, and Mr. Burkhalter commented that they were not anticipating the customer service experience that was required, I believe was the quote that he had said. How, even though it undercut the Beacon proposal by $50 million, how woefully inadequate was the Optum proposal that it was so unprepared to be able to take over and provide these benefits to these folks?
Some comments, and then I will follow up because I want to answer your question directly.
Yeah, so we, during the bid process, asked that very question because there was a gap. The original contractor was being paid $20 million a year. The new bid, the low bid, was $27 million a year, $7 million over, and the incumbent's bid was $37 million a year. So they submitted a proposal that was double what they had received in the last year of the contract, and we could not justify that. Optum had the highest technical score by the evaluation committee, and so when you look at the numbers, it wasn't that they underbid the thing; it was that the incumbent way overbid it, and they should have known better because they had the contract to submit a bid that was double. But we're not paying less today. We're paying $27 million a year rather than 20. Go ahead, Mr. Secretary.
Yeah. Delegate Resnick, I thank you for bringing up the February meeting because we did our best to level with you about the situation at that time. We did not candy coat it because it was a troubled transition. But I think the record will show that through the year of our Lord 2020, everything that we could do to get this thing right, we did, notwithstanding the other things that might have distracted us. We have daily progress meetings with this organization. The other thing is that the estimated payments that I made the order when I found out that this was not going to work the way it was supposed to actually supported the industry through the pandemic. If we hadn't done that, we would have had to find a way to do it, because once the orders went out that you could not go see your doctor, people on a fee-for-service basis were going to starve. So, and the last thing I'll say is that, again, this is an estimate, but they got $163 million more during this time period than they probably would have. So I think that this department did everything it could to make this right, and the statistics that we shared with you today show that we're starting to hit our marks. And the one thing that's most important to me as secretary is I bought some additional components so that we could guarantee you and the people of Maryland that the services that are being rendered are rendered properly in a high-quality manner and fiscally accountable. That did not happen with the predecessor vendor, and this was a piece of progress that had to take place. It was a lot harder than any of us wanted it to be, but I think we're in a much better place now, and we'll be able to hit our marks from here on out.
Thank you, Madam Chair, and I guess we'll see by the next budget hearing where we are with this. Thank you.
Thank you, Delegate Resnick. Delegate Valentino Smith.
Thank you, Madam Chair. For the Secretary or Mr. Schrader, at this point, you stated that you do believe you'll be able to hit your marks. And my question is, at what point, or are you in a position to be able to ask that the subcontractor in Cato be replaced and move things along? Because it appears that it's a subcontracting arrangement that Optum chose to make that has probably caused most of the dysfunction.
I think Chad's probably the best person to respond to that. He's closer to it than I am. Chad?
Yeah, I'm happy to address it, Mr. Secretary. So first of all, I would say that the state has some very unique and specific requirements which made the use of the Encato tool appropriate and necessary. The state of Maryland has some different compliance-oriented regulations that, frankly, many of our Medicaid partnership states do not have, and so that made it necessary that we leverage this tool. By the way, I do want to clarify a comment I made earlier. The vendor I mentioned that we are replacing is the call center vendor earlier. You know, the systematic support we're getting is from a company called InfoMC, and the tool is called Encato. But our focus, Delegate, is to get the tool performing right now. We feel like we have good clarity around where, you know, the challenges have been. Frankly, much of the feedback that we have been receiving through some of the letters that some of your colleagues have referenced, they're equal part systematic questions as well as some policy and what I would call execution differences, and in many cases not inappropriate differences. So I think we have to separate, and we're working to separate, where are the concerns and issues that are more related to helping to educate providers on what the state's policies will be going forward, and separate those to one side. And then from an accountability perspective with my team, making sure that we're very clear on what defects or issues, or frankly, even just reconfigurations need to be made in order to make Encato perform better. So our focus right now is on getting Encato to perform, and we absolutely believe that we will get there.
Thank you. Thank you, Madam Chair, and we look forward to seeing you at the budget hearings then with the update.
As long as you're convinced that you can get it to work, could you tell me when it is you are convinced you will get it to work?
Madam Chair, was that a question to me? I just clarifying?
Yes, it was. Mm-hmm.
Yeah.
I'm wondering what the timeline is on that.
Yeah, so I appreciate the question. So right now, we think that the tool is performing significantly better than it was previous. So we think we're actually not that far off the mark today. However, there are significant and specific challenges that specific provider groups or specific services that have been problematic for certain providers. We are working hard on those throughout December, and we think that there will be material progress in the first quarter. And we absolutely believe that the tool will be highly functioning, even more highly functioning and appropriate, by the end of the assisted reconciliation process that Secretary Schrader referenced in his comments earlier. So as we work through the first half of the year, we'll continue to see improvements. I think some of those improvements won't only be defect-oriented, but will be enhancements as well, which are aimed at things that providers as well as the state would like to see adjusted.
So what I hear you say is that you're optimistic that by the end of a year of working on this system, it's going to be working?
Well, like I said, I think that where we are today is, we feel confident that in the $32 million that's being distributed each week this week and a 14% denial rate, we think that those indicate reasonable performances today. But that said, there are very specific issues which over the next quarter will be addressed, most of which will be addressed over the next quarter. But we absolutely, as Secretary Schrader's already referenced, we believe that we'll be in strong overall position absolutely by that period. So I just want to clarify, I'm not saying that it'll be fixed by a year after. We think we are functioning better now, and we will be functioning much better in the coming quarter.
Well, frankly, that's a little bit disheartening. With that, I have background noise. I may be moving, so try not to pay attention to my relocating. Delegate Lewis.
Thank you, Madam Chair. Thank you. My video is not coming on, but hopefully that doesn't matter to you guys. Thank you, Secretary Neal and your team. My question is for Mr. Burkholder. You mentioned that there was a pattern of difficulty of certain providers are experiencing greater difficulty with your software system than others. You said specific providers or specific services. That makes me curious whether there's a pattern or a trend in obstacles to getting care for certain populations. I wondered if you could be a little bit more specific about that.
Thank you, Delegate. So what I'm specifically referring to are examples where claims may be paid, for example, at a day short and need to be reprocessed because of a specific service type or a specific provider type, where their configuration was much more difficult or frankly not as well understood. I think that's heavily connected to the comments that Secretary Schrader made relative to the need for improved documentation. And so some of the items that we're wrestling with right now are items that were not as clearly understood at the time of the layout of the requirements. They are becoming better understood, unfortunately, as providers had experienced some challenges, and we're working actively to address those. As far as individuals not receiving care, I think I would have to yield to my colleagues for additional comments, but I would say that the data does not indicate that in the least. And we have been successful in ensuring authorization, and then we have been working hard to manually ensure support of payment for those same services. So I may yield to my colleagues for additional support on that, the remainder of that answer.
And so I would agree in that we are not the Behavioral Health Administration aware of any patients who have not been able to receive care that we have not been able to address very immediately. But in general, I cannot say that I hear very many reports at all about people not being able to care because of this issue.
But I'd just like to press a little bit. You said you haven't heard many cases, but does that mean there are 0 cases? I'm just curious about the pattern and if we're looking at certain populations of patients or certain type provider organizations having greater trouble than others. They might need a little bit more attention.
So in terms of this having a direct impact on patients being able to access services, most of the work that Chad is referring to is what happens on the back end with regards to payment-related issues. From an authorization perspective, in terms of people being able to access services because of authorization issues, that we have not heard a significant, I cannot say that I have heard any reports about people not being able to get authorization. That's a very significant issue, and if that's something that comes up, it's something that's dealt with immediately so that people do have access to the services that they need.
Thank you so much. Thank you, Madam Chair.
Delegate Riley.
Thank you, Madam Chair and Secretary, for this presentation. Actually, Delegate Valentino just asked my question about the serious flaws in the operating system, and I believe Chad did his best in answering those for us, so I'm good. Thank you.
Okay, thank you. I have one last question for Secretary Neal or designee. You talked about, was it a technical advisory or assessment committee that you used in making the decision on this bid? The first question is, were there only 2 bids for this contract? And the second question is, could you describe the technical people who you used to consult, since we seem to be having so much technical difficulty with this?
I cannot recall or recite who it was, but I'll be happy to get you the information of who they were and what their qualifications were, their resumes and whatnot. But I really couldn't answer it right now.
Well, that will be fine. As follow-up to the meeting, we'd appreciate the answer to that question, including, as you said, what their background is. And about the number of bids that you had on this, were there only 2 people interested?
I'm almost sure that we just had 2 qualified bids. There may have been other bidders that eliminated some components. I can't recall who they were, but you ended up with 2 qualified bidders.
We'll verify that.
Maybe you could document that.
I will add that to the response that we will get to you.
Great, I appreciate that. And apparently I missed Delegate Belcastro. I apologize, Delegate. Are you there?
Yes, thank you, Madam Chair. My question was answered by when Delegate Lewis asked her question. Thank you.
Okay, great. I'm still wondering how I missed you. Oh, there you are. I did just plain skip right over you. Not intentional, Delegate Belcastro. Mr. Secretary, are you looking at me? It looks like you're looking in a completely wrong direction, Mr. Secretary. Oh, I see. Your camera is in a different place than your screen somehow. That's fine.
Yes, ma'am.
This has not been a wonderful hearing, and I want to be careful to not let it cloud the work that you have done serving as the secretary in this position. I know you came back to us and we're grateful for your service. We appreciate having been able to work with you. And I just want to say on behalf of all of us, thank you very much for your service. And I hope that your next phase or endeavor is just wonderful.
Thank you for your kind words.
You're welcome. Bon voyage, so to speak. Although I'm sure you're not getting on a ship right now.
No, ma'am.
Okay. Stay safe and stay healthy. With that, we're going to move to the next part of this briefing, we're going to go to the providers. If you would begin, presumably Lori and then Ann, but whatever order you've decided is just fine with us.
Thank you, Madam Chair and Chairman Resnick. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. And I have with me today Lauren Grimes, the Assistant Director of CBH, who's here to answer any specific questions about authorization and claims payment. And Dylan, thanks for doing the honors. If you would switch to the next slide. I'll try to go through these as quickly as possible. I know you have another briefing. Just in terms of our members, we have 85 organizations throughout the state. These folks have been in operation for an average of 44 years. So long before the first ASO came into play in 1997, our providers were providing services, getting authorizations, submitting claims, and doing so successfully. This is actually our fourth ASO, and you've never heard a peep out of us before because by and large, these transitions have gone fairly smoothly. We always expect some bumps in the road, but nothing like this. It would really be hard to overstate the disruption that this transition has brought to us. And at this point, we are frustrated and exhausted at a time when we really need to turn our full attention to the impacts of COVID on both our clients and our staff. Next slide, please, Dylan. So this is just to show you that it is a complicated system. Our provider organizations offer multiple lines of service, and these are reimbursed in different ways. So we have things that are reimbursed on a fee-for-service basis. We have things that are reimbursed on an encounter, a monthly encounter basis. So you have to submit a minimum number of encounters to submit a bill. And we have things that are paid for on a per diem basis. And this is no doubt contributed to the problems that Optum has experienced. But again, in the past, our ASO vendors have been able to grapple with this and do it efficiently and well. Next slide, please, Dylan. So this is the timeline of the ASO transition. You can see we're now in our 17th month. There was sort of a run up from July of 2019 to go live. And when it was clear that the go live was a failure, we asked the department, please, to give us these advance or estimated payments. And to their credit, they did so. We knew that they were a necessary evil, but without them, we would have gone under. And the reason I say necessary evil is we knew there would come a day when we would have to reconcile all of this operation and come up with who is owed what and in what direction. You can see there were multiple dates where this Optum system in Cato was to go live and it couldn't do so. You all stepped in at one point and actually allowed the estimated payments to continue for a period, and we are thankful for that. Unfortunately, when it did finally go live in early August, the issues that we've been dealing with continue. And one of the things I'll just stress is that when you look at the Optum data that shows that their claims payment in aggregate looks a lot like Beacon's, the difference is that Beacon's were for current claims. So you would expect that claims after August 3rd would be paid and it would be a certain aggregate amount. What we were seeing after August 3rd were claims that were paid for current, but a lot of claims that were actually paid for through the estimated payment process. So it inflated the numbers, and actually providers were paid twice for the same service, which of course we don't want. And we've been putting that money aside. But that's why the numbers look similar, but it's really comparing apples and oranges. Next slide, please. So one of the biggest issues that we have with the Encato system is the lack of accurate reports. Without these, providers cannot do revenue cycle management. They simply can't. And these are not bells and whistles reports. These are things that any payer, whether in the public or the private sector, should be conversant with and able to do. And we've been promised these reports for quite a while now, and we get them, and they're erroneous, or only some providers get them. They're still not a standard operating procedure. And without these things, we can't track what has been paid, what has been denied, and why. Do we need to resubmit? And so all of these things have to be addressed before we can even hope to do reconciliation. Next slide, please. So just a couple of examples of things that we're seeing. And these are both from specific providers, but they're representative of our provider base as a whole. So on the left side, you'll see a provider that submitted about 149,000 claims. But on the right, you see that these same claims were processed and reprocessed, anywhere from 1 time to 21 times. And so you'll have a claim that's submitted. It may be denied the first time, reprocessed, paid at the wrong rate, reprocessed, denied again for a different reason, and this goes on. And what that does is not only require the providers to sift through all this information and try to figure out what was paid and when, but it also means that the denominator, when you're talking about denials and other things, the denominator is greatly inflated because of this claim inflation and reprocessing. So it throws and skews the numbers. On the right side, a different problem, and these are encounter problems. So psych rehab, which serves some of our most at-risk populations. So this provider submitted $7.3 million worth of claims, but was paid $5 because $2 million worth of encounters are just missing. They disappear in the system, they can't be found. When they finally go back in, they find them, but that means the provider has already been paid the wrong amount and we've got to go back again. Next slide, please. So Optum's response has been, since the technology can't do the job, is to institute manual fixes. So what we've got now, in a time of great complexity of billing and service delivery, people trying to process claims. And the problem with it is, of course, human error. So we're seeing different kinds of problems arise, and also lags in payment, which our providers can least afford. The analogy I use is really buying a car that turns out to be a lemon. So you bring it home, and the first day the power windows don't work. And the second day, the radiator leaks. And the third day, the transmission slips. And it's just a series of issues, very different ones from time to time, that compound and change until the consensus is that this system just can't be fixed. Next slide, please. So these are some of the issues that we have seen with the Optum system. Some very basic problems. So we have providers that continue to get paid for other providers' work, organizations that are receiving checks for other organizations' work. Of course, shouldn't be happening, not to mention the HIPAA potential violations inherent in that. Insurance types. So everybody knows in the public behavioral health system, our clients go on and off of Medicaid. Sometimes they get Medicare, they're then dually eligible. And any payer in this system has to be able to handle those different insurances. Optum's system has not been able to do that. In fact, we've seen clients denied for services because they have dental insurance, clearly not associated with behavioral health. And one of the biggest issues is the processing of clean claims within 14 days. Optum says they're doing that. Our experience is very different. And again, we've been through other ASOs. This has not been an issue for us in the past. Beacon, for whatever problems the department had with it, paid very quickly. We have not had this issue before. Next slide, please. So now we're at that place where we're having to pay the piper for the estimated payments that kept us afloat. And we need 3 things to do reconciliation. We need technology, we need the right tools, and we need time. I want to again thank the department. We have been, according to our providers, they're saying it will take a year to sift through. This is hundreds of thousands of lines of data. And it will take a year to really get through that. We appreciate the department hearing us and at least extending the reconciliation time. But until we have the tools, those reports that I spoke about earlier, until we have that kind of information available and the technology that allows us to electronically post and deal with the information, then all that does is extend the period of time to come up with the wrong answer. We don't want to withhold payment back to the state, but we want to make sure that Optum's math is correct. And there's nothing that we've seen so far that gives us that kind of confidence that we can trust Optum to do so without being able to double check it. Next slide, please. So this is just, again, a restatement of some of the things we need for reconciliation. The one thing I will point out is that we have had major problems with the customer service part of Optum, and I'm glad to hear that at least the call center is going to be replaced because we are being put on hold, getting different answers from different representatives. It takes weeks to get a response back. We don't get a claim number that we can then follow up. It's a number of different problems that cast a bad light on this reconciliation process. Next slide, please. So just in closing, we're at a point where we already know prior to this pandemic, the state was experiencing an epidemic, and that was opioid-related deaths. It was rising suicide rates. All the arrows are pointing in the wrong direction right now. Some of you may have seen a recent Lancet article that said that those diagnosed with COVID, 1 in 5 is likely to develop a mental health disorder, most likely depression or anxiety, and that those already with a mental health diagnosis are 65% more likely to come down with COVID. So we're dealing with it on both ends. We need a robust provider network. I want to thank the department in particular and Optum staff. We have been meeting with them regularly, twice weekly at least. And even prior to the January 1 date, I can remember being on the phone with COO Schrader, Christmas Eve, New Year's Eve, trying to get these things right. 17 months later, we still don't have it right. And I will just say that it's not just providers that are concerned about this. We're trying to insulate consumers from harm. Our providers continue to serve people even if they can't get an authorization or if the authorization is taking weeks to get. If we're not getting paid, we're trying to insulate them, but that can only go on for so long. And we really hope that Optum will think seriously about replacing Encato as its vendor. All those changes are painful. It's painful for them. It's painful for us. But thinking of 4 more years of this level of dysfunction at a time where we're about to be hit is just unconscionable. So thank you so much for your time. We very much appreciate it.
Madam Chair, I'm Ann Seacott, Public Policy Partner. I'm speaking today wearing a couple of hats. I'm representing both the Maryland Association for the Treatment of Opioid Dependence and the Maryland Addiction Directors Council. Vicki Walters, who's the president of MATOD, is available to answer any questions that members may have specific to substance use disorder programs. These two organizations are the statewide associations representing the continuum of treatment programs for people with substance use disorders. Every type of provider has had and continues to have problems with this new ASO. The providers with these organizations, like their partners who provide mostly mental health services, would rather this new ASO and its IT vendor Encato work, wishing it had a functioning system, especially during this time, during the pandemic. No one wanted estimated payments. It was something the state was really forced to do, and that had to happen in order to make sure the system didn't collapse. We appreciate the countless hours the representatives from the department, from Optum, and from our community partners have spent troubleshooting and trying to make the system work since January 1st. But we have no faith that it is possible to fix this inflexible system. And because of these deficiencies, we do not have faith in the accuracy of the department's estimates regarding overpayments to providers. Authorizations and payments take much longer than they did under the previous ASO. According to a survey that MADC members did, it's taking Optum twice as long as the previous ASO to approve authorizations and remit payment for services delivered. We are appreciative that our concerns about the reconciliation process have been heard, and the health department, we're happy that they're proposing this more realistic timeframe. But I cannot stress enough, every single treatment program has had to significantly change how it operates because of the pandemic. And diverting resources to these administrative burdens is something that we simply cannot continue to do. You've heard how inaccurate and incomplete information is given to providers, making reconciliation time-consuming, difficult, and sometimes literally not possible. And how communications between providers and Optum is slow and confusing and inconsistent. I don't know that we believe that there are fewer problems that are resulting in fewer calls. I think from what I hear, providers are simply frustrated in not getting responses and getting different answers from different people. Every treatment program has spent untold administrative hours trying to work within this new system. Every treatment program will need to spend significant more hours in the reconciliation process. Some programs have had to hire new staff already to help with the volume of administrative work. This is not an efficient way to run any business, let alone a healthcare program during a pandemic. It is also important to note that while we've been focused at this hearing on the impact of Optum's failure on treatment, the impact on treatment programs, Optum also administers non-clinical funds, including payments to recovery residences. They too have suffered the 1-2 punch of a dysfunctional ASO and a pandemic. All of this is happening at a time when we're seeing an increase in opioid overdose deaths. Recent data from the state also shows the growing racially disparate impact of overdose deaths in Maryland. We should be focusing our attention on addressing this crisis, along with the significant increases in depression and suicide, rather than the overwhelming time and resources being spent on this IT failure. We ask for help as we try to figure out how to make the improvements necessary, and consideration of Encato maybe not continuing to have the contract as the IT vendor.
I don't see any questions in my panel, but I'm sure they're coming. Here we go. Delegate Resnick, you're next.
Thank you, Madam Chair, and thank you to Ann and Lori for coming on and providing that testimony. I had a totally different question planned, but I wanted to ask either one of you, whoever feels appropriate. You've all addressed some of the concerns that you're facing with reconciliation. Can you go into a little more detail about what providers are facing with regard to having to go through the process of reconciliation, and ultimately what is the concern from providers about if reconciliation doesn't work, if they have to pay back millions of dollars or have to go through a long extended process? What is going to be the effect on the provider community if this process is drawn out or fails?
I'd like to, if it's okay with Ann, turn that over to Lauren Grimes to answer, please.
Good afternoon. Thank you, Delegate Resnick. I think there are a number of challenges to reconciliation. One that the first that comes back to the idea that Lori Doyle pointed out in her PowerPoint is there are 4 industry standard reports that guide revenue cycle management for providers, and 3 of them are not working. And so providers are incapable of checking Optum's math, and we're dealing with as Lori said, kind of an apples to oranges issue where many providers have been overpaid or paid twice rather, for claims submitted during this estimated payment period, and are being significantly underpaid for new day claims. So those things need to be balanced out, and we don't have the tools to be able to follow those claims through each reprocessing iteration that they have gone through. So as Lori said, a claim is denied, then it's reprocessed and paid at the wrong rate. So you have claims in excess of, they're submitted at 150,000, and you have 250,000 that you're having to weed through. And the Encato limitations, additionally, all of that manual labor that Optum is taking on the customer service side because Encato does not work, is also being taken on by providers. So there are search functions that providers need in order to search by process date or service date to find the information that they need to reconcile, and they aren't there. So I believe that the very first question in this briefing was around the ability of providers to download mass amounts of claims and search things, and they don't have those capabilities. So they have to do it one by one by one. And the volume can't be understated. It's astronomical. And as Lori indicated, we have no confidence that the numbers that we're receiving from Optum are indeed correct. And there needs to be transparency through this process so that providers can ensure that they are getting paid correctly.
Thank you. A lot of these problems sound similar to what we're having with unemployment insurance as well. And ironically, Beacon is the one that's messing that one up. So thank you again. Appreciate it.
Pardon all my moving, but it turns out the people are doing the lawn next door and it's unbelievably noisy, and I don't want you to all have to hear that. Delegate Bagnall, you're next.
Thank you, Madam Chair, and thank you, Lori and Ann, for being here today. And I wanted to follow up on something that you said, because I'm concerned about the additional costs to providers for the additional need for staffing, but also what the delay is in training the staff. So if you can speak a little bit to what the average staff is who was doing these reconciliations, and the need of how much you've had to increase on average, and what the training cycle is, if that is also creating increased delays in reconciliation.
So I'll answer to the best of my ability. Thank you for the question. We've not done any kind of survey of providers to find out the answer to the question about exactly how many have had to hire how much additional staff. I have heard it repeatedly by programs and on Zoom calls like this. I see a lot of nodding heads when somebody says they've had to do this. So I can go back and ask that the programs try to put some objective figures on that. In terms of training, I don't think the problem is training. I think the problem on one hand is the volume, because you're talking about so many months worth of back claims. But the problem, as I understand it, and I'm not going to get in the weeds on this. If you want somebody to get in the weeds on it, I've got Vicki Walters who would be happy to do it. But it has to do with the kind of information that the providers are receiving back from Optum. And I understand that it is incomplete sometimes in terms of the payment remittance items that come back, the way the claims are explained. Then there are issues sometimes with the amount paid, that sometimes it's not the right rate of reimbursement. And it's just this continual back and forth between the provider and Optum, trying to get correct information so that they can then go back and match claims to payments and make sure that they are not being overpaid or underpaid. So it's a problem with being able to get correct, accurate information in order to do the reconciliation process.
Thank you, and thank you, Madam Chair. If I could just follow up, if it would be possible to survey that question, so we have a better picture as we're looking at how to address this and how to make some of these providers whole. I think it would be beneficial to the committee. Thank you, Madam Chair.
Madam Chair, I think it's my turn. Delegate Krebs. This question is for Mr.
I thought I said it, and I apologize.
That's okay.
Yes, it is.
Mr. Burkhardt, you all started off by saying that about 14% of claims were deficient. But it sounds like from listening to the providers that the problem is much greater. And I think Ms. Seacoat mentioned that every type of provider is having problems. Can you just tell us how you talked about a period of time, but how are you tackling this problem? I mean, are you doing it provider by provider? Because it seems like there's so many issues. I don't even know where you're starting. Can you just describe to us how you're going about moving forward for all providers? And the 14% just does not seem like a realistic number considering what we've heard.
Let me interrupt here. This is a little bit out of order because the panel that you're addressing now is not the panel that's up at
Oh,
this
you're right.
time. But I think that everybody who is listening to this has the same question. So in this case, I'm going to break all my rules and I'm going to ask Mr. Burkholder if you would be willing to answer the question because I think we're all wondering the same thing. Thank you.
Thank you.
Thank you for the question and thank you for the opportunity to answer it. So exactly, Delegate Krebs, as you described, is exactly how we are approaching it. We are looking at the denial performance of every single provider to understand which ones are performing well, those that are seeing very few denials, and which of those are seeing a significant excess. I referenced in my comments earlier that we have done about 300 meetings with specific providers, especially those who have outlier performances. We're seeing significant denial rates, 20%, 25%, 30%. And what we find in those discussions, they've been very fruitful discussions. They've been an excellent collaboration between the organizations. In most cases, what we're able to do is we're able to clarify a submission error or a change in state policy that the provider may not have been either aware of or being attentive to. In other cases, we're saying, hey, we believe that this is paying correctly. Let's do it live. Let's look at this example together. And in some of those cases, we actually do find specific challenges. It could be anything from a data problem with a fee schedule, or it could be a systematic Encato issue. And then we're working with our partners at the provider within MDH, as well as with our vendors, to make sure that things are addressed and improved. But I think exactly as you hypothesized is exactly the approach that we're trying to take in terms of really looking at this provider by provider and then attempting to influence that both through written communication, engagement through the councils that Secretary Schrader mentioned earlier, and that and also through some of the different events, the town hall events and things like that, and then of course sitting down one-on-one with providers. I hope that that's addressing your question, Delegate Krebs.
No, thank you, but there is an urgency that's it's already passed, and I understand you're working in difficult times, but this is an urgent situation that we've heard over and over again from all providers. So thank you for understanding that urgency.
We do. We understand it, and we're working very diligently to try and address it.
Delegate Riley.
Thank you, Madam Chair. Yes, both Laurie and Ann have suggested that they have no confidence in the reconciliation process because of the operating system that Optimum is using, which is Encato. Have either of you suggested or have talked to Maryland Health Department about, or Optimum, about this change? And if so, what was their response? And is it something that they can actually possibly do at this point? Thanks.
I'll take a stab at it, Ann. Yes, we have. CBH has clearly recommended that Encato be replaced, and not just CBH, but there have been letters sent from the Behavioral Health Coalition that had over 80 signatories on it asking for the same thing. I think some of these may have been distributed to your committee. I think probably part of the problem is that if Encato's system is seen to be working from the perspective of Optum, but clearly dysfunctional from our perspective, we have a meeting of the minds issue. And so unless there's a clear understanding that Encato is dysfunctional, I don't see anything happening with it. And that, I think, is the problem.
Thank you. Did you, I'm sorry, as a follow-up question, Madam Chair, if I could, have they responded back to you? Or is it possible for them to do that, or they're not considering it? Are there other companies or softwares out there that can do it?
I can't answer the latter part of your question, but they have responded to our concerns, basically to say if individual providers have problems, they can come to Optum or they can come to the department. This is beyond an individual provider issue. This is a systemic issue. And so again, I was happy to hear Optum acknowledge the deficiencies, but it is far beyond what their data would indicate.
Okay, so no real confidence that that system will be changing. They're just making improvements to that system.
I think if they could have fixed it, if they could have fixed it, they would have. I mean, everybody's been working on this. If they could have fixed it, they would have.
Okay. Thank you very much. Appreciate it.
Thank you.
Thank you, Madam Chair.
And I'm on the move again, as you can tell. I apologize, but maybe this will work again. So that leaves us to say thank you to the presenters. And now we will move on to the second half of our briefing.
Thank you all.
We'll ask Dave Smolsky if you could start us off.
Yes, I am unmuted, I see.
You're unmuted. I can hear you very well.
All right, so overview or a PowerPoint is coming up on your screen right now. This is the brand new Legislative Services PowerPoint format. We hope you enjoy the new colors and the scheme. And it's a little more exciting than what we used to put up. So I'm here my name is David Smolsky. I'm staff to the Department of Legislative Services, and I'm here to provide an overview of hospital debt collection practices, mostly in Maryland, but with some examples from other states. If you go to page 2 of the presentation, there's 4 parts to this presentation. I'll first start off by covering Maryland's existing law on debt collection policy for hospitals. That's in Health General Article 19-214.2. I'll also briefly go over American Hospital Association debt collection guidelines. I will give some examples of other state debt collection practices for hospitals, and I'll wrap up with a brief description of the legislation that was submitted last year, which expanded the debt collection law in Maryland that would govern hospitals. That was House Bill 1081 of 2020. Next slide, please. The current law in Maryland that governed debt collection policy for hospitals was passed in 2009 and then amended in 2010. In 2009, hospitals were required to submit their debt collection policies to the Health Services Cost Review Commission. And then the contents of this policy was specified in law. Some elements of the policy include oversight of contract to collect debts, prohibiting the selling of debts, or charging interest for self-pay patients until there is a court judgment. There are also various procedures provided in the debt collection policy that they would have to meet, including a procedure for patients to dispute the hospital debt collection actions. Also, on the next page, in the 2009 legislation, HSCR, or the commission, was tasked with studying a uniform debt collection policy for hospitals. So they issued their report in 2009. And in 2010, legislation passed that implemented about 36 or so of the commission's recommendations. So in addition to what was done in 2009 by requiring the hospital to submit their policies to the commission, more specifics were added relating to debt collection policies. First off, there was provisions relating to patient refunds and eligibility for free care. So a refund must be provided if a patient was determined to be eligible for free or reduced care. The refund had to be issued within 2 years of the date of service. The time could be reduced, however, to 30 days if the patient did not cooperate with the hospital's request for information. There were also specific provisions relating to consumer reporting agencies or civil actions, or when a hospital may refer a debt to refer non-payment to a consumer reporting agent, or take an action to collect the debt. Most importantly, I would say that the most significant thing was a time frame was put into the law in 2010, saying that the hospital can't take any action until 120 days after billing. This time may be reduced, however, if the patient does not cooperate with the hospital. And again, if the patient pays off their debt, they have to report to a consumer reporting agency within 60 days that the debt was satisfied. Next page. There are more provisions added in 2010, which is the existing law. A hospital is prohibited from forcing a sale, or in other words, you can't sell or foreclose on a patient's property if they don't pay their debt. However, a hospital may put a lien on a property. There are also procedures for hospitals regarding the delegation of debt collection to an outside agency. These are more specific than just saying, what you would have to tell the commission you were going to do. The collection activity must be specified by a contract between the hospital and the collection agency. And the contract must include that the collection agency is also required to have the same procedures regarding collecting a patient's debt that the hospital must follow. So if the requirement applies to the hospital, it would also have to apply to the collections agency under contract. These reports are collected by the HSCRC, and we asked the commission where we could find the reports, and they're included in their community benefit report. They're part of their community benefit reports on their webpage, but they're very difficult to access, and the commission is redoing their webpage. So if you wanted to see each hospital's policy in the future, you would be able to go to the community benefit report and locate it. Right now, that's very difficult to do. Next page. So along with the state law, the American Hospital Association issued guidelines regarding that would give guidance to states and state hospital associations about debt collection policies. The guidelines were first established in 2003, and the last revision was in 2019. The American Association of Hospitals, or American Hospital Associations, encourages hospitals to review their billing policies and how these are presented to patients and the public. Also, the guidelines consist of action plans, resources, and specific federal requirements for tax-exempt hospitals. All three of these will be summarized in the next slides. Next page, please. Under action plans, a hospital must consider a bill should consider a bill from a patient's point of view. They should review all communications relating to the bill to the patients and others. They should engage their boards and staff on the development of a hospital's debt collection policy. And probably most importantly, hospitals should mind their compliance with IRS 501R requirements. These are the requirements that a hospital must meet to maintain their tax-exempt status. If they don't meet these requirements under federal rules, then their tax-exempt status may be jeopardized. On the next page, in developing their action plans, various resources are suggested to be used by a state or a hospital or a state hospital association. These resources are listed below. They include hospital billing and collection practices, statement of principles and guidelines. This is developed by the American Hospital Association. Other guides they suggest to use when developing their debt collection policies are the Healthcare Financial Management Association's Patient Financial Communications Best Practices. And then there was a joint publication put out by the previous mentioned organization and the Hospital Association, Avoiding Surprises in Your Medical Bills, a guide for consumers and understanding your healthcare prices and a consumer guide. On the next page, you'll see what some of the federal requirements are that a hospital would have to make to maintain their tax-exempt status. Hospitals are not allowed or basically prohibited under federal rules to take extraordinary collection actions, which are identified below, unless they make a due diligent effort to work with a patient to collect their debt or determine they're eligible for financial assistance policy. These same requirements would apply if a collection agency also went into extraordinary collection actions without exercising due diligence. And finally, when a hospital is required to presume that the patient is eligible for his financial policy assistance first. So in other words, there's presumptive eligibility that somebody is eligible for assistance in a hospital. On the next slide begins a couple of pages of other state policies. The most recent data I could find it listed a compendium of all states was done in 2017. And around 2017, about 16 states had laws regarding debt collection policies, and 5 states or so use the American Hospital Association guidelines. Either they tell the hospitals to do this, or the state hospital associations adopted these guidelines for their hospitals. So on the bottom, you'll see I've picked out a few states here. In California, in Maryland, it's 120 days before action can be taken for a non-payment of a bill. In California, that number is 150 days. California law also limits wage garnishments or liens on primary residences. On the next page, Colorado provides that you can't take any action until 30 days after you send written notice to the patient that their debt has not been paid. In Connecticut, hospitals are prohibited from collecting more than providing the cost of service, so you can't collect more than what they were charged. And Illinois, a patient, they may not refer a patient to an agency unless the patient was given an opportunity to request a reasonable payment plan. On the next page, there's more state-specific information. Minnesota operates under a consent decree between their attorney general and hospitals, and also some laws regarding hospital debt. And in Minnesota, each medical bill must be reviewed by the hospital before collection actions commence. In Nevada, they have the same 30-day period. In other words, you can't commence an action until 30 days after you send written notification to the patient. And Nevada also has an interest charge limit on any debt, which is 2% in Nevada. North Carolina, you may not be referred to a collection agency while eligibility is pending, and they also have the same 30-day requirement regarding a written notice. The last couple slides deal with last year's legislation. This was health facilities, hospitals, medical debt protection. That was House Bill 1081. There was also a Senate bill, but I believe the Health and Government Operation actually did some work on this bill. The Senate wasn't able to get to it. This House Bill 1081, in a nutshell, would expand and add to and specify existing state hospital debt collection law. It modifies what a hospital is required to report to the commission, what information they have to report under the first part of the existing debt collection law, but it also adds additional provisions that aren't in the law right now and expands on it, provisions that are already in the law. First, it establishes interest on hospital debt. Right now, there's no interest requirements in the law, but this bill would have specified a 1.5% interest charge on outstanding debt. It would have specified that there was no interest accrual until 100 days after the later of the discharge or the end of the regular billing period. So no interest could be charged in a period of time until 180 days have passed. Next page, please. It also established installment plan provisions. Under current law, there's nothing regarding an installment plan provision, but this bill would have specified that each patient incurring debt must be offered an opportunity to pay off their debt in an installment plan, and it also provides more details about the installment plan. There was also additional reporting provisions that relate to before you go to a consumer reporting agency. Under current law, it's 120 days. The bill would have taken out a number to 180 days of non-payment of debt before you would go before the information can be reported to a consumer reporting agency. There is no reporting if the patient was eligible for financial assistance, and other provisions were added relating that a hospital must abide by before report the information to a consumer reporting agency. Next page. There were changes to the lien provisions of existing law. Under the bill, liens would be prohibited. And again, no debt payment collection actions may be taken until 180 days after non-payment instead of 120 days under existing law. It would also have established a limit on how much on dollar amount for a hospital before it can take action. There is no limit in existing law. This would have set a standard of $5,000. So anything under $5,000, there could be no debt collection actions taken by the hospital. There were also provisions added regarding debt collection actions by the hospital. And probably the most significant one that would have been added by the bill was 45 days before a hospital takes a debt collection action, they would have to provide written notice of the intent to the patient. Other states have done 30 days. This would have been a 45-day period, cool-off period, I guess you could call it. On the next page, and the final page. There are also additional provisions for There are also additional provisions added relating to authorized debt collection complaints. Each complaint that before a hospital initiates an action, they have to attach an affidavit to their complaint to go to the court, and the contents of the affidavit are specified in the law. And there's also liability that was added to the bill. If a hospital uses a debt collection agency, both the hospital and the debt collection agency would be jointly and severally liable for their actions. And additional reporting requirements were also added for hospitals to the commission, as well as the commission to the General Assembly and the governor. That concludes my overview of hospital debt collection practices. I'd be glad to answer any questions you have.
Are there questions from the committee? Actually, I saw one. Delegate Young, we'll start with you.
Don't think I was first, but I'll take it. My question deals with financial literacy and resources. Could you tell me what process is in place to educate a patient on their ability to qualify for financial assistance, or to review the process for finding resources? And how do you monitor that process over time to make sure, assuming there is one, that the patient receives some counseling and awareness of opportunity?
I don't think that was part of anything. It's not part of the existing law for debt collection practices. There's nothing about financial literacy resources or education there. I know another bill passed last year, passed the General Assembly, was enacted regarding debt collection or financial assistance. And I don't know if actually there was a financial literacy component to that. I would imagine the Maryland Hospital Association might be able to tell you what they're doing, what their hospitals are doing regarding financial literacy, but at least in the bill that was proposed last year and in existing law, there's financial literacy is not addressed.
Opportunity, thank you.
Opportunity.
I'm sorry, Delegate Cullison, your name.
Thank you, Madam Chair. Thank you, Mr. Smolsky, for that really comprehensive report. It's really very helpful. I think you might be the right person to ask because you know the law as well as you do. In terms of eligibility for financial assistance, we're in a situation now where someone may have had a procedure in January and then wasn't able to work after that, not because of the ailment, but because of COVID. In some cases, when we're not in a pandemic, it might be because of the situation. And so their eligibility changes from the moment they had the procedure to, or the intervention to when they're actually billed. Are they eligible to not, for charity assistance if they become financially eligible during the billing process, not at the time of the event?
There's nothing in the law that addresses specifically that addresses that situation. Obviously, I've heard that this is becoming a concern because of the pandemic. I would imagine, and this is just conjecture on my part, that if somebody all of a sudden can't pay their bills, the hospital be willing. The hospital, I would hope, would want to work with them on that. There's no limits on when you can or are not eligible for financial assistance, or at least not in the law that I can find. I don't know if hospitals have policies on those limits. Again, this would be something the Hospital Association could provide a little more information on, but the law is pretty silent about how long the law is silent right now on how long you can be eligible for financial assistance.
Okay, thank you. That's really helpful. Thank you, Madam Chair.
Delegate Bagnall.
Thank you, Madam Chair, and thank you very much for your presentation. I actually had a follow-on question to Delegate Cullison, who asked my question is in terms of change of status, not just in your financial status, but if the law speaks at all to change of household status, because that would, obviously change your financial situation.
Now, I mean, again, there's nothing in the law really, that, at least in debt collection, that talks about change in status. And I don't believe also in last year's bill that you passed regarding financial assistance, a change in status is directly addressed. Again, it's hard to say how a hospital would react if all of a sudden somebody stops paying their bill. I would think they want to work with them because they want, nobody wants to not get paid or wants their bills to be paid. So I would think at least a hospital would try to work with somebody initially before they started taking action down the road if that becomes necessary.
Thank you.
But again, the current law does not address change in status of the patient or the household.
Okay, thank you.
Delegate Lewis. Delegate Lewis.
Sorry, Madam Chair. I do not have a question. Thank you.
Thank you, Mr. Smolsky. You did a great job. We really appreciate it. Next panel is the Maryland Hospital Association for an overview of financial assistance policies and debt collection processes.
Thank you, Madam Chair and committee members for inviting us to join you today. And really appreciate David's overview of some of the current laws and requirements of hospitals, and appreciate the committee's insight. You've asked a lot of good questions that we actually do plan on addressing today. So Chair Pendergrass, we will make sure we're mindful to address each of these. There was legislation passed last year related to expanding financial assistance. Delegate Robin Lewis led that charge in the committee. And you'll hear more from us and also from the Health Review Cost Commission in terms of implementing those. And many of the questions that were asked just now about some of those standards, literacy, and some of the eligibility are part of some of those new requirements. So we'll make sure that we touch base on that. Today joining me is our CEO and President, Bob Atlas. Bob will be speaking today really from the consumer's perspective about what is really driving medical debt. Want to reiterate a hospital's commitment to care. I think that's been more apparent here during the pandemic than ever before. We'll also speak about the overview of hospital practices related to financial assistance and billing. We are also joined today by Godly Davis. She is president and CEO of Deco Recovery Management. Godly has over 20 years of experience in supporting patients with financial assistance. She is going to walk through with the committee very in-depth perspective about financial assistance process and policies and practices. So I think you will learn a lot from her presentation. I just want to note for the committee at the end of your packet material that we provided today, that we do have a number of reference both to state and federal laws. Mr. Smolsky covered many of those, but that is in your packet. There are also a number of flow charts that we will speak to today that I think will really help with the overview of the steps in the process. And so with that, Chair Pendergrass, I'd like to turn the presentation over to Bob Atlas. Bob.
Thank you, Jen. Good afternoon, Chair Pendergrass, Vice Chair Pena-Melnick, members of the committee. My name's Bob Atlas, President and CEO of the Maryland Hospital Association. And as Jen did a nice setup, we'll go on to the next slide if we may. So, as has been noted several times, we're in the middle of pandemic. We have over 1,000 COVID
patients in hospitals today, and our hospitals are, and their frontline caregivers are doing their level best to treat everybody who comes to them. And as always is the case, our commitment at Maryland hospitals is first and foremost to our patients, to make sure that they get the care that they need without regard to their ability to pay, without financial hardship, to the fullest extent possible. When patients don't have the ability to pay for part of their care or all their care, there are financial assistance programs, payment plans, charity, reduced cost care, and so on. And when we do get into the debt collection arena, we try to make that as patient-friendly and as transparent as that sort of transaction can be. So, and as you know, there's been legislation already passed, and there's legislation pending, but we, we continue to work. And as you'll see, Maryland is ahead of most of the rest of the country on this front. Let's go to the next slide. So just for a little bit of context, let's not forget that, part of the reason for these challenges that we're seeing is that people's insurance has gotten markedly skinnier. As you see on the right-hand side, this is a national perspective over a 10-year period. Deductibles have gone up massively, premiums gone up significantly above inflation and wages. In Maryland, over the 6-year period of 2013 to 19, premiums rose 24% and deductibles grew 55+%. And this is in a period when our hospital costs did not grow nearly as much on a per capita basis, thanks to the Maryland all-payer model, followed on by the total cost of care model. Let's go on ahead. I don't intend for you to follow this chart, and I would say this chart is actually a simplified version of what really happens. Patients pay, when they experience a healthcare encounter, they've already paid their premium to the insurance company. The insurance company gets a claim from the provider. That might be the hospital, that might be a physician, a lab, MRI provider, you name it. Everybody generates separate bills. That claim is reimbursed minus the patient's cost sharing, and so the provider or hospital must bill the patient for their cost share, and it's the cost share that they must pay. This diagram doesn't even begin to talk about out-of-network providers, and all of our hospitals are pretty much in network on in all the plans that operate in Maryland. So we're not talking about hospital issues on out-of-network. The fact of the matter is that this is so complex that hospitals have dedicated staffs, and they also rely on contractors to perform these functions. And so what I'd like to do now is turn to Godly Davis. She is president and CEO of DECO, which assists many of our hospitals on working with patients on their financial needs. And she'll explain in much more eloquently than I can on exactly how these processes work.
Good afternoon. And I want to thank the committee for the opportunity to come and provide some insight on the financial assistance process for the hospitals. If we can progress the slides, I think 2 slides, one more. So the first slide, what we'd like to kind of walk through are the steps and the practices that are common and standard among a lot of the hospitals for assisting patients with financial assistance. We've broken it into kind of 4 categories of that assistance that's provided. And so the first is assisting with obtaining the documents that are needed to apply. And so as you're going through the financial assistance process or
which usually includes also possibly qualifying for Medicaid and other potential benefits to help that patient pay for their services, there's often information that's needed to be supplied for that process. So of course, patients often have to provide ID. And as simple as that may sound, there are oftentimes patients that come to the hospital for a number of reasons that may not either have an ID or may have had a situation even where their ID was stolen, they were a victim of a crime, and now there's an instance where they need to have that information in order to apply. The hospital provides assistance even with helping obtain IDs, with referring them to different programs that will assist with that. And then other documents like death certificates, birth certificates that are necessary for both the patient and often family of patients to apply and be assisted with the benefits and programs that are available to them. And so the hospital actually designates particular representatives in the hospital to assist with this. There's a number of different roles, whether it's in what the hospital referred to as patient access, or the registration staff that check the patients in, to designated financial counselors that kind of talk the patient through the financial options that are available to them and provide a lot of that healthcare literacy that's been discussed. Many patients don't really understand what they have as far as insurance. And particularly as we get into some of the, we'll talk through a few examples as we move along, but there are patients that have insurance, and when they have high deductibles, they really don't understand that they are effectively uninsured for a certain amount until that deductible is met. And so being able to explain that and assist the patient through that process is critical and happens at our hospitals on a daily basis. And so those individuals that provide that education are also assisting with providing the information and access to the information that's needed to apply for financial assistance, whether it's explanations of benefits after the services have been rendered and their insurance provider has provided what they're going to pay, itemized bills if you're in a situation where that's needed in order to meet, the qualifications for a spend down or something else for Medicaid. But even going out of their way to actually make visits to the patient's home, sometimes patients aren't able to bring documents back. They may be homebound, they may have conditions that limit their ability to travel, or it may just be something where it's a financial limitation where they just can't get back to the hospital to provide the documents. And the hospitals partner with organizations like my organization and others that will assist with actually going out to the patient's home to help pick up documents, to bring them information, to complete applications on their behalf. One of the other areas I'm looking in the second block that the hospital provides service is really tracking down the person who can provide the information. Very often when a patient is coming in, they're not always in a state where they can readily provide or even receive the necessary information about financial assistance. When they're in, if they're in distress and a significant amount of pain, often those conversations are ones that at that time they may have had, but it's not really able to sink in because of the immediacy of their medical needs. And so very often then the hospitals end up having to help follow up and identify family, next of kin, and it takes sometimes extraordinary efforts to do so. There are times when patients come in as a John Doe and you need to figure out what happened, and there's research that they're doing online. We've even had seen where hospitals have had to go onto social media profiles to try to identify who the next of kin may be for someone, who else may have been involved that might have more information about what's going on with the patient. Of course, trying to review previous admissions to see if there's information available. So if we know who the patient is, but you're not sure about their insurance information or their ability to pay, being able to look at what's been available and what was provided on previous admissions, and then even working with the different payers and insurance carriers to find out what information they have listed, making those phone calls to determine who the family or next of kin may be, who we can talk to and discuss the options that are available to the patients and what the next steps will be. Another area that that hospitals look into is also checking whether it's a state, a federal, or even credit agency databases for information that can assist the patient in qualifying. And some of that collaboration is with, vital records. We already talked about death certificates and birth certificates. Some is with the IRS, being able to assist with getting information on employment and income, so that the patient doesn't necessarily have to provide it if they don't have that information readily available. There's additional assistance at often at times to get that information where the hospitals are getting that directly, or getting an estimated household income or estimated FPL through some of the other credit reporting agencies. And then the fourth area would be also contracting, which we mentioned some with vendors in this space that do assist with applying for Medicaid and doing some of this outreach. But also many hospitals have Department of Social Services caseworkers that they contract with that are right on site at the hospital to make it easy for the patients to actually apply for benefits and get more information about the benefits that are available. There's also partnerships with the in-person assisters, whether it's navigators, certified application counselors across the hospital. So there's lots of people that the hospital employs really to assist the patients through this process and to provide information and guidance and education about the different options that are available to them. Next slide, please. So just recently, this year, House Bill 1420 was passed, and there's some enhancements that the hospitals have put in place in order to address some of the changes that were in this House bill. One of the areas where we've seen some increases and changes were in the financial eligibility threshold. Quite a few, for financial assistance, quite a few hospitals already had thresholds that went up to 400% of federal poverty level. And there were some that already either met or exceeded the 500%. But what we've seen is that the hospitals have increased that eligibility threshold to that at least that 500% of FPL to provide that assistance to individuals that are up to that level. The other thing is that there was a requirement to remove asset tests that were not currently present for Medicaid eligibility. And so for many of the Medicaid programs, there is not an asset test any longer. And there were certain things like retirement plans and first $10,000 of certain assets that have now been removed from financial assistance policies from the hospital. So many of the hospital policies are no longer using any of these asset tests. And if so, they've been increased to taking into account the House Bill 1420 changes. The other area, there were some questions about the healthcare literacy, and one of the things around that really that has really increased that is making available these plain language summaries about financial assistance and being able to provide that in multiple languages for the patients so that they have that and they're able to have that as a resource. And these are made available. They're easily accessible from the hospital's website. They're often provided directly to the patient, either at point of discharge, point of registration. There's information that is posted around at the hospitals regarding this information, just to make it easily accessible. But the plain language part is really what's important to explain in that's not in ways that's not in this medical jargon that may be more difficult for patients to understand, and often in their own language. And then the other areas with developing complaint and appeal process procedures. This is both through the HSCRC and the HEAU, where you're looking at making sure that the patients know if they do have a concern, who they can go to, making those phone numbers available, accessible, and how they can reach them, as well as if they disagree with the decision, how they appeal it. And that also includes instances where a decision may have been made early on, but now their situation has changed, and they're looking to provide new information to show that now they're having difficulties in being able to provide, to pay for their bill. And then finally, another of the components was the preparation of an annual financial assistance report, which details the number of people who've actually filed applications, number of people who've been approved, who've been denied, and hospitals are preparing and gathering this information to be able to provide in that financial assistance report. Next slide, please. So we spoke a little bit about the financial and the health literacy piece, but when you're looking at trying to get a patient to understand, what they're now responsible for, whether it's an uninsured patient or an insured patient, there's a huge undertaking in really educating that patient. And so I talked about like financial counselors and some of the other people who are involved in this process for the hospital. They spend a lot of time really explaining the process to the patient and then provide a lot of information. So whether it's at the point of, when they first come in, when you're registered and you're going to be seen, at that point, they're collecting the patient's insurance information. And one of the first questions, is providing the insurance information. If a patient doesn't have insurance, or if they have an insurance where their liability is definitely going to be something that's what we look at some of these high deductible plans. There's often discussions right at that moment to discuss, if there's any difficulty or inability to pay, what that patient would be responsible for. And that patient often at that time is provided, is provided the opportunity to get information about it. If they want more information about financial assistance, they can be provided the plain language summary. They'll also be told that information will be provided to them again at other points, is available to them on the website. And of course, even when they enter the hospital, it's posted on the walls at the registration booths and available to them. So we've provided just a few examples from some of our partner hospitals of information that's provided to the hospital. And just if you look at the first example, I know it's a little hard to see, but in that example, that this hospital actually provides assistance up to 600% of federal poverty level, which is even more than what's required in the current House bill that increased the limits. Next slide, please. So this timeline of financial assistance ability really goes through the time period that a patient has to apply for and get assistance with financial assistance. So beginning from the time the patient discharges and when that first statement is sent, there are multiple opportunities where the hospital provides information and is assisting and screening that patient for potential eligibility. And so generally when you're looking at inpatients at that time, when they're discharged, there's a discharged interview and there's information that's provided at that time that if they don't have the means to pay their bill, there's information about financial assistance and here's how you can apply. From that point, whenever there is any follow-up on the bill, and generally what we've seen is on average, most hospitals do about 4 follow-ups, and this is telephone call outreach, their billing statements that go out, and those statements each include information about financial assistance. That's a requirement. It's something that's across the board for all of the hospitals. And at the time that the patient is finding out what their responsibility is, they also receive information about how they can get help if it's needed. And that's a piece that's really important because sometimes when the patient gets that information at the point of registration or early on when they're sick and they're in the hospital, they don't really know what they're going to be responsible for. And sometimes, they'll even decline additional information for financial assistance. But now when they're finding out, here's what I'm going to be responsible for, it's at that point, they also have the information that, and here's how you get help if you're not able to meet this requirement. And so with multiple, as you see in this process, multiple opportunities to follow up and receiving that information multiple times. The first time that they can get a notice is at day 90 that would indicate that there's a potential that their claim can be sent for debt collection. They would get that notice already in advance, and then it cannot, the earliest it could be sent for debt collection would be at 120 days. But at that point, there's been multiple attempts as well to provide assistance and to make the patient aware of what what that option is, and that would include the opportunity to create a payment plan. But during that process as well, and before those debt collection processes begin, there are also, the hospital conducts what are called presumptive eligibility checks. And I talked about leveraging credit scores and other information from other partners that they can use to determine a person's potential eligibility. And this is something that the hospitals do in batch prior to sending things to collection. They're checking to see, is this person's estimated federal poverty level or household income at a level that is low enough to meet our presumptive criteria for financial assistance? And if they do, this is something that happens automatically. Instead of going into the debt collection process, that claim would then be written off into presumptive financial assistance. And so that's even when the patient doesn't respond and doesn't provide any additional information and doesn't even have to actually file an application, there's an opportunity, and this is a check that's done on every patient to make sure that people that don't have means aren't, or to try to ensure that people that don't have means are not going into that debt collection process. And then this continues all the way until day 240. This is 8 months that the patient has to apply for financial assistance. So during this period, as some questions have been raised, of course, the patient's situation can change. Their financial situation can change. They can lose income. They may have lost a job. And if that occurs, they have this entire process to reach back out to the hospital and to provide that information. And as soon as the patient indicates that there is a financial need to apply for financial assistance, any collection efforts cease at that point. And that's an important thing to understand, that this is really, when the patient lets the hospital know there's a need, that those collection efforts will stop. And that's something that happens across the board through the hospitals. So by this point at day 40, there's been multiple opportunities and multiple sets of notices with information about financial assistance that has then been provided. And this is inclusive of even some telephone calls where then the patient can directly ask questions and be provided more specific information to their situation about what's potentially available to them. Next slide, please. So the next few slides illustrate a couple of patient profiles of some typical patients that the hospitals deal with on a daily basis, and kind of what their process would look like going through the financial assistance opportunities. So this first profile is of a 27-year-old patient that does have insurance, but it's a high deductible health plan. And this is often common with some of the younger patients. They get these plans that have lower premiums, but they're higher deductible. And so this patient is brought into the hospital unresponsive, and they're brought in by a roommate. Well, because of the privacy and HIPAA regulations, the screening and information that's needed to determine if this person would qualify for financial assistance can't be done with a roommate, but we can request maybe if they know information about who the patient's next of kin, like parents, spouse, siblings may be, that the hospital can then follow up with and assist with conducting that screening. And so then the hospital would make those contact attempts with research to find who they can get in touch with and make attempts to contact someone and to determine if that is an option for financial assistance for the patient. If the patient then, at some point during the stay, if they then become alert and they're able to interact with the hospital, then that conversation then will be had again with that patient directly to have that conversation and determine, if they're able to pay the portion that's their responsibility or if they need assistance with it. And then if they do need that assistance, to kind of walk through that process with them. If they discharge before the patient completes the financial assistance application or provides the information that's necessary, then those attempts by phone and by mail will occur with that patient. And if when they receive their billing statement, they identify, you know what, I do need assistance, and call back to the hospital or talk to someone when they call them and say, yes, I'd like to make assistance. They have up into that 240 days. And at that point, they can say, get reviewed, and then they provide information and actually qualify to be placed in a payment plan that will make it a reasonable plan for them. And often these payment plans take all shapes and sizes, lengths of time, to work with the patient around their need and what is feasible for them in a payment process. Next slide, please. This next example is a typical example, an uninsured patient, and unfortunately all too common that we experience in the hospitals with patients that are homeless. So the patient comes into the emergency room and they actually, because they are uninsured, could get immediately routed to a financial counselor to assist them with applying for financial assistance. But unfortunately, because the patient may not be in a state where they know all the information that's needed, that application is incomplete. So there's follow-up that's needed to be done for that patient in order to finish that process and get all the information to determine, to complete an application. And so for homeless patients, hospitals, I mentioned the home visits that they do. Well, in addition to that, even if the patient is homeless, that outreach would be done with the homeless shelter, if there's a shelter that the patient frequents. Often even in conversation and discussion, there's been visits that are made if it's known that a patient lives under the bridge, is seen at a certain a certain area. There will even be visits made to those areas to try to do the follow-up that's necessary. And those are the kind of extraordinary efforts that the hospital is making to be able to provide assistance. But ultimately, even if that information isn't provided and that patient never completes the application, many of the financial assistance policies include homelessness as a presumptive eligibility criteria. And so in this situation, that patient would likely be automatically written off to presumptive eligibility because of their state of homelessness, even if they don't cooperate with providing the needed information. And then if you proceed to the next slide, we provided in the interest of time, we have provided for your reference 2 other patient profiles, one on an uninsured patient, and then the next slide is referencing a patient that is a Medicare patient and kind of what that profile would look like going through the process. And we're definitely open if there are additional questions. But at this time, I'd like to turn it back over to Bob Atlas with MHA to discuss a little bit more about the medical debt and financial assistance takeaways.
Thank you, Ms. Davis. That was really remarkable how much reality you were able to give to it. Really appreciate you giving that perspective. I just note over the interim since last session, our MHA got together with our hospitals, both in survey and in one-on-one discussions with our members, and to learn exactly what they're doing. And what's on this slide actually matches something that Ms. Davis just said. Patients on average are contacted 4 times and given assistance to apply for, given a chance to apply for financial assistance before any collection actions are taken. They take at least 30 days to notify a patient, they give 30 days notice before taking any collection action in writing. And patients have 8 months and sometimes longer after discharge to apply for financial assistance. And to a point that, let's go on to the next slide, to the point that was asked of Mr. Smolsky, I think Delegate Cullison asked this question, if a patient has a change in their financial circumstances after the event, the hospitalization, there is flexibility to modify the financial aid request at any point. And so, and hospitals do take that into account. Likewise, once the application is filed, there's no new collection actions begun,
and ongoing actions are suspended while that application is being processed. So, again, so many examples of what I guess I would call bending over backwards. Let's go to this will be, I think, our final slide. So, I think it's worth noting again, Maryland is already well ahead of most other states. We're equal to or better than just about all states in the country on consideration for our patients. And of course, everywhere we're facing this challenge of the growth in deductibles and essentially making people exposed to costs, and the insurers are making people exposed to costs in ways that they never were before. There was legislation in the last session to advance Maryland on this path. MHA supported that legislation. There was also separate legislation on disclosure of outpatient facility fees, and we are working with our members across Maryland to implement that legislation to the better effect on our patients. We always do try to mitigate the consumer's cost exposure. We hope to see advances here. We've got ideas on simplified billing that would require insurers to play a stronger role in easing the process for consumers. We're committed to transparency. Payment plans are always there, and extensive notification that goes on. So, we have our own statute. We are ahead of others. We are committed to work with this committee and others and our regulators to make sure that there are fair and equitable policies and practices for financial assistance, charity care, collection, and so forth, and to take account of the demands of our unique total cost of care model, as well as the federal requirements that pervade it in addition. So we know this committee will see some new or returning legislative proposals. We hope that what we've talked about will help you understand how to consider what's coming, what these new proposals are, and what's consumer cost exposure really like. With that, we'll end our prepared remarks, and I'm back to you, Madam Chair, for questions.
Thank you very much for all that information. We're going to start with Delegate Lewis.
Thank you, Madam Chair. My camera's not working, so I'll just proceed. I really appreciate the presentation. Thank you, Mr. Atlas and your team. A question occurred to me, lots of questions, but I'm only allowed to ask my best one. And so I think I'll direct this to Ms. Davis. You did a great presentation. You gave some great examples, some case studies. There was a case study you referred to in which a patient who's experiencing homelessness is seen in the ER. And you described a process in which that person applies for financial assistance. My question is, why wasn't that patient immediately deemed presumptively eligible for Medicaid? The way that the bill is framed makes it easy for hospitals to perform presumptive eligibility for someone with specific criteria, homelessness being one, that doesn't require an application for financial assistance. This means that I'm wondering if we're still stuck in some old practices rather than really using the simplifying tools of that the bill provides, for example, presumptive eligibility for someone with homelessness.
Thank you very much for that question. That's a great question and distinction. In this situation, it's a high likelihood that that patient would also be eligible for Medicaid. And unfortunately, the Medicaid process does not enable this automatic process. So we would be trying to gather information to get that patient Medicaid eligibility first. If they unfortunately are not able to get
to get the information to us where they would have that Medicaid eligibility that would enable them to get the health care and follow-up that's needed, from any, Medicaid provider. Then we would, of course, go through the financial assistance process, but we're going through these extraordinary efforts in order to assist them with also getting additional benefits.
I thank you, Ms. Davis. I guess what maybe I'm slow. What I'm not understanding is if someone presents who's clearly experiencing homelessness, there's no need to interrogate and investigate for additional documentation. That's what the bill does. It frees the hospital. It actually saves the hospital administrative effort of evaluating eligibility and just says, treat this person as Medicaid eligible. And I was also curious, a person clearly experiencing homelessness should immediately be, enrolled. My understanding is that there are navigators or employees who are capable of just taking care of that enrollment on the spot. So I'm really confused, and that makes me worry that the bill's not doing what we wanted it to do. So thank you.
You're welcome. And unfortunately, it doesn't take away the requirements that Medicaid has. There are still additional requirements that are necessary for the patient, even with those difficult situations to comply with for Medicaid. But the hospital does, of course, what they can on the financial assistance process.
Thank you.
You're welcome.
Thank you, Madam Chair.
Thank you. Delegate Carr.
Thank you, Madam Chair. Thank you for the presentation, and just want to express my appreciation to your members and all your workers during this pandemic.
Thank you.
My question is, I read that Johns Hopkins Hospital had stopped filing lawsuits against patients for medical debt. Is that true? And if it's true, if your biggest member can do that, what is to stop additional members from following that practice?
I don't know the answer to the question on Hopkins, but I can say that we do have a number of members that don't sue. That is a choice of the individual institution based on its determination of how it will conduct its financial policies. There's a range of decisions that hospitals make on that, we have to acknowledge that both federal and state laws do require hospitals to pursue collections, and they have different avenues to do that.
The ones that don't sue, do we know if they're any worse off financially than the ones that do practice suing?
I could look into that. I think that this is a changing process. I think that if you look at we'd have to compare, for instance, hospitals in Maryland, which are all not-for-profit, save one specialty hospital, to what goes on in other states with for-profit institutions that exist in many other states. We can look into that and follow up and give you an answer.
Thank you.
Delegate Cullison.
Thank you, Madam Chair, and I want to thank everyone from MHA for this really comprehensive presentation. I really appreciate it. And thanks for clarifying that 240-day period after discharge. And my understanding is, from your presentation, that indeed, if a person's financial situation is changed, then they can reapply or apply if they hadn't applied already for eligibility for financial assistance. And I'm really grateful that the collection process stops once the person begins the application form. The question then for me becomes, and I hear presumptive eligibility, but what if the person, I need to be clear though, if the person reaches that 500% level for the federal poverty level,
would they then be automatically given the assistance? That's not clear. You know, in the way that you've presented the information, it's kind of like, we'll think about it, but we may not grant it. So I'm asking, is it automatic if they meet those standards that have been set?
I think I'm going to ask Ms. Davis to describe the kind of the decision tree that goes on there. I'd say generally that, you know, it's a factor that triggers action, and the hospital certainly would, you know, start to move
As
on.
we go forward, if you don't have the answer to a question, just start with Ms. Davis. Would you take that question, please? We really don't want your answer and then her answer. Thank you.
Yes, ma'am.
Ms. Davis.
Yes. So with regards to the determination for presumptive eligibility, and it is defined in the hospital's policy, and when they do that eligibility check and it comes back that that patient is under that threshold, then yes, that is a process that happens automatically. The difference that you see is that occurs at and sometimes at multiple stages for the patient, and at different times for different hospitals. In some instances, it may occur at 90 days. Other instances, it may occur at 120 days. There could be a difference in that process. And so it's really just a matter of when it happens, but it's always occurring before the collection efforts begin. And then once it happens, if the information is available to determine that they meet the criteria, they will be automatically written off to that presumptive charity.
And so just a quick follow-up. I guess I'm a little concerned that there's differentiation among policies, among hospitals on their policies. I mean, when I just heard you say timelines might be different. We saw that Adventist goes up to 600% FPL. You know, so I guess one of the things I think I want us to think about is making this consistent, at least at, you know, with whatever flexibility individual hospitals might need. But I think there's some issues around the inconsistency among the hospitals, something to think about.
And Delegate Coulson, if I may, that distinction is often, there's a requirement. Here's what must be done. All of the hospitals do that. Usually where you see the variability is that there are some hospitals that go above and beyond the requirement.
Okay, thanks for that clarification.
You're welcome.
Delegate Krebs.
Thank you, Madam Chair. And I hope I didn't miss this because I missed a little bit of Davis Molsky's presentation. But with regard to the type of debt that we're trying to collect, you talked about copays and deductibles. Is there some kind of report that shows you where the debt is coming from, whether it's those types of things, whether it's facility fees, whether it's surprise billing? I mean, do we have an idea of what where the majority of these this new debt is coming from?
I'm going to ask my colleague Brett McCone to see if he has an answer for that. He's on the line. Brett, are you able to speak to that?
Yes. Thank you, Bob. Thank you for your question, Delegate Krebs. Appreciate that. It's an important one. I think what we've seen recently, the hospitals do have that information. The expansion of the high deductible plans with the out-of-pocket coinsurance and deductibles, certainly we've seen a large increase in uncompensated care from the growth in those plans.
And thank you for the answer to that. And this is not a question, it's just a quick statement, but it seems to me when they're selling these plans on the exchange, maybe at that point we need to determine whether people can afford their high deductibles that they're getting. But I see that this is a new problem that we have, that we didn't have 5 or 10 years ago. It's just a different problem, but thank you for articulating that.
Yes, it is a relatively new problem because I've been fighting against high deductible plans for many, many, many years because of this problem. And some in another party have been fighting very hard to get these high deductible plans because some believe that people should have this choice. And now we may be seeing the downside of having this choice. So it's an interesting historical question as to the history of health insurance in the state of Maryland.
No, I guess my question was, is there any kind of accommodation on the front end to see if people really can afford their high deductible plan if the time comes and they need to use it? I mean, some people can, some people clearly can't when they purchase them.
This is a freedom of choice issue. Apparently, once we've made the policies available, people have the choice to freely choose which policy they want. We do not have the ability to tell people what they can or can't afford. That's just not in our law. You could think about a law to do that. Or you could think about repealing high deductible plans. That would be another approach to this problem.
People have to be responsible if they choose that plan. Thank you.
Yeah, thank you, Delegate Krebs, for letting us do a little historical perspective here. I appreciate that. Thank you very much to all of you for your discussion of this. And I'm looking forward to hearing that we make progress going forward. I know we have good people working on this issue. And I know the hospitals have been trying very hard to cooperate, and the Hospital Association has taken a lead role. So we'll see what we can come up with for this year to make progress.
All right. Thank you for the opportunity, and we look forward to working with you.
You're welcome. That ends that briefing, and we're now going to move on to the HSCRC update on financial assistance and debt collection activities.
Good afternoon, Madam Chair, Chair Resnick, members of the committees. For the record, my name is Tequila Terry, and I am a Principal Deputy Director at the Health Services Cost Review Commission. I'm joined by my colleague, Hannah Friedman-Bell, who is our legislative analyst. She's going to be on the line to help answer questions. We have been asked to be brief, so I'm going to walk expeditiously through a few slides that we've prepared to just update the committee on the work that we have been focused on relative to financial assistance and debt collection activities in the interim. So next slide, please. So we'll focus a little bit on just a reminder of Maryland's unique hospital system, the finance system, and then really dig into House Bill 1420 and the work that we have been focused on over the interim, and then we'll just conclude. Next slide. So I think you all know who we are at this point. We have responsibility as an independent state agency for regulating the quality and cost of hospital services. And so we do that through, on the next slide, what we call the Maryland Health Model. So this is our unique model here in Maryland that really combines the agreement with the federal government, the total cost of care agreement, with our historical all-payer hospital rate setting system. And there's a number of benefits that this model brings to the state, including helping us to contain costs across the system, really focusing on better outcomes, helping to avoid the cost shifting that we see across payers, and really focusing on investing population health in some key healthcare infrastructure. But really most relevant to this compensation is I just want to underscore that one of the benefits of our model is that it guarantees the equitable funding of uncompensated care. So behind all of the conversation that we've been focused on today is the ability of our model to support uncompensated care, unlike any other model that exists across the country. So it's really important to recognize that our model allows us to do that. Next slide. So I won't go into detail because Mr. Smolsky did a wonderful job summarizing all of the legislation in place. But obviously in House Bill 1420, there were a number of elements that required action, both from the hospitals as well as the HSCRC. So I'll just talk specifically about what we are doing as an agency. Next slide. So over the interim, in response to House Bill 1420, we've been taking a number of actions designed to help hospitals implement the requirements in House Bill 1420, along with making sure that we provide the analytic support that was requested through the bill that was assigned to us. So first, to start off with, we issued a memo to hospitals on House Bill 1420 specifically that was designed to encourage hospitals really to understand, read the legislation, and make sure that they are enacting steps to ensure compliance.
As part of that memo, we emphasize the requirement to have presumptive eligibility for free care in place. And so as we have been talking about presumptive eligibility, I do want to underscore that presumptive eligibility for free care has been a requirement in COMAR, and that is an important step that we want to make sure hospitals are moving forward with. Additionally, we took steps as required in the bill to formalize and really simplify the consumer complaint management process. So we have had a long-standing history of working with hospitals to manage consumer complaints. However, there was an opportunity to formalize the process. And so we have now set up a centralized email system to be able to receive complaints, and issued a memo to hospitals to make sure that they're aware of the new system and ensure that they are including language about how to submit complaints to the HSCRC as part of their process and as part of the touch points that they have with consumers. We will also be issuing regulations or updating regulations to make sure that COMAR does in fact also have the same information on the consumer complaint management process. Next slide. The next thing that was called out in House Bill 1420 was really an assignment to the HSCRC to do financial assistance modeling. And this we will be providing to the committees shortly. It's due January 1. And what we're doing is really working with the Comptroller's Office, Medicaid, CRIS, DHS, really to model out various potential changes to the eligibility for various financial assistance programs. So whether it be free care, reduced cost care for patients with hardship, medical debt, and then presumptive eligibility for reduced cost care. And so we've got the bill called out a variety of scenarios, 6 different scenarios that were assigned to us to model out different changes in eligibility thresholds and really understand what the cost would be, what the impact would be, particularly for making more people eligible or qualified for those programs. And then to sort of comment on our view of the effectiveness of those potential changes and understand what the data might indicate about current rates of eligibility for those financial assistance programs. So we are working, we just last week, in fact, received a data file from the Comptroller's Office. So our team is in the process of analyzing the data. And really starting to think through what are the key components that we'll want to share with the committees as it relates to these potential changes in eligibility thresholds. Next, we are also working, sorry, I shouldn't have said next slide. The next thing that we're focused on is new annual financial assistance reporting. So the bill actually called out specific new reporting guidelines for hospitals, really with the goal of making sure that hospitals provide information on all of the various scenarios that exist relative to financial assistance. So the reporting will provide information on the number of patients who are actually completing applications for financial assistance, and then the number of denials, the costs for free care that hospitals are providing, and then looking at those with the lens of race, ethnicity, gender, zip code, so that the committee has a greater appreciation and understanding of what the implications are on various demographics across the state. And so because of the attention that hospitals have needed to pay to the pandemic, we have submitted a request to extend this to December of 2021. I understand from the prior presentation that hospitals are starting to collect this, but we believe that it's reasonable to give them a bit more time on this. And so there's a request that we have submitted to the committees to start this annual report in December of 21. Next slide. In addition, outside of the work focused on responding to House Bill 1420, we've also been working to update regulations, really to make sure that COMAR is aligned with the language in House Bill 1420, and particularly to make sure that, as we've heard in the prior presentation, that financial assistance should be equally accessible by all patients, regardless of their insurance status. To the point that was made, so many more people are struggling with paying medical bills now, even if they have health insurance, particularly if that health insurance comes with a high deductible design. And so part of the regulations that we will be proposing will be to ensure that financial assistance is equally accessible to all patients. And then finally, we are working with hospitals to really start to understand what are the opportunities to improve when it comes to our audit performance or our audit procedures, really identifying what are the best practices that have been identified and what are the opportunities to improve, particularly as it relates to financial assistance policies. And anywhere that we have been seeing issues, starting to work directly with hospitals to make sure they understand exactly what we're seeing in audit reports. Next slide. So in conclusion, over the interim, we've been really focused on taking steps to ensure that hospitals implement the various components of House Bill 1420. And we've also been collaborating with other state agencies to gather information to perform the analysis that we think will be very helpful to the committee as you start to think about future opportunities to improve financial assistance procedures. And so as we think about where we go from here, we will continue to review the fiscal year 2020 special audit results. So those are the audits we've just completed on hospitals. As Mr. Smolsky mentioned, we are in the process of updating our website to make it more transparent for consumers and interested parties to understand about hospital financial assistance policies. So we have a new section that we are designing that will make the policies more readily available to the public. We will be submitting our proposed regulatory changes to AELR before the deadline this year, so that hopefully those can get implemented as early as possible in 2021. We will be completing the financial assistance threshold modeling that I referred to. So looking at those 6 changes that House Bill 1420 outlined in eligibility thresholds, and really identifying the opportunities understanding any opportunities that exist as a result of that analysis. And then finally, our goal is to continue to improve any special audit procedures, the oversight of hospitals. And so we're looking forward now to fiscal year 21 and what those procedures should entail, and very much focused on making sure that we do follow up with any hospitals on any specific issues that have been identified. So I will stop there. I think that's our last slide. We have a few other slides in the appendix for your reference, but I want to be cognizant of the committee's time. So would welcome any questions that you all may have at this point. And Chair Pendergrass, I think you're still muted, so we didn't hear what you said.
Well, did that work?
Now we hear you, yes.
Good. The button used to work and now it doesn't. Delegate Cullison, why don't you start?
Thank you, Madam Chair. And thank you very much for that presentation. That helps me know what the commission is doing. Had just 2 things that I think are quick.
One is, what's the current FPL that our waiver, that's existed under our waiver without causing us anxiety? So, you know, because I know that you're looking at increasing that standard a little bit, so I want to know where we're starting. And is there any consideration of, when we look at eligibility, just going beyond that FPL and saying, if you're spending, you know, X amount of your income on insurance costs, that would be calculated into the consideration for eligibility?
Sure. So there are a variety of thresholds that exist relative to the current qualifications for free care, reduced cost care for patients with a hardship, and for medical debt. So I'll just sort of outline those for you. So for free care, the current threshold for qualification is at 200% of FPL. So patients with a family income at or below 200% FPL. For reduced cost care, it's at a threshold of family income between 200 and 300% of the federal poverty level. For reduced cost care, for patients with financial hardship, that is where it comes to the 500% FPL. And for medical debt that exceeds, for medical debt hardship, the debt has to exceed 25% of family income to qualify. Okay. So the way that it's laid out today is it depends on the actual program, the type of financial assistance that comes into play for the actual threshold.
Mm-hmm. And that's where we might be actually consider that role of insurance in there.
Correct. Yeah. And so that's where, again, I think our modeling is going to be helpful, because what we are modeling is, what if, for example, if today the free care threshold is at 200% or below, what if we increase that to 250 or 300 or 350? What would the implication be on cost of care? What is the extra spending that would result in for our model? And so the bill actually lays out various iterations of changes that we would be including in our report. I think important to note, the modeling that we're doing also is going to look at, you know, how successful are we today under the current thresholds. So one of the things we really want to understand is whether or not a change is actually necessary, or if we need to do better simply complying with today's threshold. So part of our work will be to look at both of those issues. And so again, we look forward to providing the committee with the full analysis. I must say that, you know, COVID has thrown a bit of a wrench in our timeline. And so we had hoped to have the data much sooner, but we do have it now, and we're working through the process to start to do that analysis. I must say the Comptroller's Office has been, you know, wonderful to work with. They have provided us with information that will allow us to match up, you know, sort of hospital data with wage data. And so we will do our best to bring those two sources together really in a way that paints a picture. Now, I will also say that it won't be a perfect analysis. There will be, you know, several things that we'll have to caveat in the data where we may not be able to perfectly match hospital data to, you know, comptroller wage data. But it will be an indicator that we think may be useful to the committee. So again, we'll look forward to providing that information.
Great. Thank you very much.
And the last question of the day goes to Delegate Lewis.
Thank you, Madam Chair. I was rushed before, and if I didn't say it already, I really do want to commend the Hospital Association as well as HSCRC They've been in great communication and are working really hard. Everyone's doing their part to move forward with protecting the people of Maryland from undue financial burdens in healthcare. I want to thank everyone. I want the chair to hear me say that. You guys are great. You're doing a great job. My question, Ms. Terry, just to make sure, are we on track to get your final analytical report by December 31st?
So we are doing our best. As I noted, we just got the data within the last 7 days. And so I think I would love to have our team look at the data, make sure there are no issues. And by the first week of December, we'll have a really good sense of whether or not we are on target for providing that report. So I will reserve the right to perhaps come back to the committee if we find issues. But at this point, we have the data, and that's a really good step in the right direction for doing the analysis.
Thank you. And thank you all.
There was a button that was working and now it's not. We're going to have to figure that out. Thank you all for putting up with this platform approach to doing our business, the people's business. And I know it's hard for everybody, but it was done very well. I really appreciate everybody's cooperation today, and especially Delegate Krebs's sense of humor and Delegate Charkoudian's hard work on this issue. Thank you for joining us today. With that, we have some briefings still scheduled between now and January, and the public can look at our website on the General Assembly webpage to see what the schedule is. And members have been all given the schedule, as well as will generally get reminders and Zoom links and those kinds of things. So I really appreciate your participation today, and that goes for our members, our visiting members, and the public, and our guests. So thank you very much all, and I'll see you again soon. Bye.